All right. Good morning, everyone. Welcome. This is the Advisory Committee on Infant and Maternal Mortality, and I'd like to call the meeting to order. I'm Vanessa Lee. I'm the designated federal official for the committee, which is administered by HRSA's Maternal and Child Health Bureau. It's so good to be with all of you. We haven't met since, I think, December of last year, so this is technically our first meeting of 2023. So Happy New Year to all of the committee members and ex officios and members of the public joining today. Thank you for being here. A lot has happened, and probably the biggest update I wanted to share is that we have a new committee chair, Belinda Pettiford. So hopefully all of you saw the announcement on our committee website. Belinda is no stranger to all of you, the committee, or to those of us in maternal and child health. She has over 30 years of experience in public health and currently serves as the chief for the Women, Infant, and Community Wellness section within the North Carolina Department of Health and Human Services. She was an advisory committee member also from 2018 to 2022 and served as the co-lead of the Health Equity Work Group of ACIMM, or the Advisory Committee on Infant and Maternal Mortality. And I see a lot of virtual applause, Belinda, in the chat. Congratulations, Belinda. I am so excited to be working with you again. I had the opportunity first back in 2012 to meet and work with you on an infant mortality initiative called The Coin. It's kind of hard to believe 10 years have passed and we're sort of still here working on a lot of the same issues, but I'm nevertheless excited and happy to get to work with you in this new and different capacity. I think there's a lot that can be done with your leadership. So again, thank you for accepting the invitation to serve another 3-year term and to be the new chair. And so with that, I'm going to turn things over to you, Belinda.
Thank you so very much, Vanessa, and thanks to everyone for all of the positive comments, the emails, the text messages that have come my way. Please know no one was more surprised than me to get the request, but here we are, and I truly look forward to working with each and every one of you all. Can we remove the screen so we can all see each other? Just thank you. I like to see people when I'm speaking. So again, so very good to see you all. Hope you had a wonderful weekend and that your March has started off amazing. As I tell people, my birthday is in March, so I celebrate the whole month. I don't want to rush people to feel like they've got to get to me by March 14th. I do the whole month. And so it is so good to be with you all today. And at this time, I think we'll go into introductions. And because this is March and it is Women's History Month, we thought our introduction today should connect to women's history. So today, as you introduce yourself, if you can talk about that one person, that one woman in your life that has truly inspired you, been influential in your life, and tell us a little bit about why. And so everybody can think about that while we're doing introductions, and I'll kick it off since I knew about it and give you the rest of you a moment to think about it. Again, I am Belinda Pettiford. Here in North Carolina, I get to work with an amazing team, and this was a very easy question for me. Again, I had a birthday this month, but my mother lives with me, and she is 89 years old, and she has been inspiring me my entire life. She'll be 90 this year. As she said, the Lord is willing. She'll be 90 this year. And I can easily tell you why. Now, my mother has been at the forefront of everything in my life. She has been an activist, as she would call herself, from early on. I have 2 older sisters that actually integrated the high school in my community. And it was because my mother said, "You're going to do this." I'm sure my sisters did not volunteer, but she said, "No, you're going to do this." And every time an issue came up, my mother was the first to be on that school grounds, making sure she was protecting my older sisters. And they learned a lot from it. And she was an advocate for that. She's the person that's been doing voter education and voter registration my entire life. She inspired me to go in and get into the work and do voter registration and voter education and to work as a judge in my poll in the community. But mostly all is the love she shows for her family. She loves us all. She has, it's my siblings. She's got great grand. She's got great grand, and she has one great grand. And so the fact that all of us can come together and she keeps us engaged, she has always been an inspiration to me and continues to do so. And we look forward to celebrating her 90th birthday coming up in June. So at this time, I am going to turn it over to Sherry Alderman for your introduction.
Well, thank you very much. Belinda, you are a big act to follow. I will do my best to humbly follow your introduction. My name is Sherry Alderman. I am a developmental behavioral pediatrician by training, and I'm pleased to be here today. I'm located in Oregon. I also, the person that immediately came to my mind was my mother, for different reasons. She was very resilient and very much a survivor of multiple adverse childhood experiences, and really enjoyed life and liked to have a good time. So she has been a very wonderful role model for me. She passed away a couple of years ago at 97 years of age, and was to the very end just very engaged, loved her children, her grandchildren, and her great-grandchildren as well.
Thank you so much, Sherry, and we'll popcorn it over to Phyllis.
Good morning, everyone. I'm Phyllis Sharps, Professor Emeritus, Johns Hopkins University School of Nursing. And not to break the tradition, but also my mom. And I think primarily my mom was a wonderful and caring woman, as most folks have described their moms. But she just finished high school, but implanted very early in the seeds of my sister and I that we were to be professional women, that we were to go to college. And we were, my sister and I are the first women in our family to be college graduates, and we both went on to have fabulous careers. So that important that we all know that in maternal and infant health, those important early years, and inspiring people to do that. And then I would also say a colleague of mine who passed away unexpectedly in January, Dr. Fanny Gaston Johansson of Johns Hopkins School of Nursing, accomplished many things. She was 84 when she died, and was educated in nursing at a time when there were not many nurses of colors, and certainly not many in leadership positions and leading research. And it has really inspired me also. Thank you.
Thanks, Phyllis. Tara Sanderly.
Hi, great to be here. See everybody. Belinda, again, congratulations. We're really excited that you're the chair. I think, like everybody else, I look to my mother. She's an amazing woman. She's here today despite many health issues, but she's just been an incredible source of inspiration and support and encouragement. She grew up on a farm in Iowa under very poor conditions. She suffered a lot of hardships, abuse, poverty, and despite all of that, I just saw her, and even, you know, under the age of 18, she suffered, she faced an unplanned pregnancy, and then adopted the boy out, and it just, you know, hearing her story and what she faced when she faced that unplanned pregnancy, and then you know, all the stress that she was under, and the conditions, he was born premature, and there were health issues. And so I've seen her, despite all these hardships, she's just worked really hard. She's trusted the Lord. She went back to school. She got an education. She made multiple sacrifices so that her children would have opportunities that she did not have. And so she's just been a constant source of inspiration my entire life, and continues to just be and encourage me along the way. So lots of great tributes to our moms.
Thank you, Tara. Charlene.
Hello, good morning or afternoon to everyone. Charlene Collier, I'm a general OBGYN, public health professional in Mississippi. So great to see everybody. Congratulations, Belinda. You are one of my heroes, so I'll just put that out there. I've known her since the very, very beginnings of my public health career and journey, and she's always been there as a just a kind face and expert, and just someone I'm so glad to see is in this role. So we'll shout out Belinda as part of those women history recognitions, because she truly has been an inspiration throughout, especially as a Black woman in public health. Like, Belinda's always been there. If it's through just AMCHIP meetings, and this is from when I was getting my MPH. I remember you being there, even probably before you knew me as even a student looking up to you. So thank you. And then, of course, have to include my mother in case she somehow gets word that I was the only one that didn't acknowledge her. But my mother is an amazing inspiration. Moved here to Mississippi to be here and to support me, someone who's a teacher. And she was a teacher of special needs children who I was able to shadow as a child and go to the school where she taught in Jersey City, New Jersey, and see how she led with compassion, not only in the students she cared for, but how she treated all her staff. And it's something I've always taken with me. And she's like, you make best friends of everyone that's in your office and department, from the janitor to the principal. They're all people that you value. And that's something she taught me from a very young age. And just someone who's always valued treating individuals with kindness. And so I honor my mother and thank her for that. But again, thank to Belinda. And if I had one more shout out, it's to Dr. Menard as well, because there's not a lot of OBGYNs who are as many role models in public health. And she's always been one for me too. So.
Thank you, Charlene. We'll try to make sure your mom gets word that you did shout her out. Okay. Kate Menard.
That took a chance on the camera, folks. There it goes. I'm Kate Menard. I'm a maternal fetal medicine specialist based at the University of North Carolina, and pleased now to be in my sort of beginning of the second year on this committee. You know, I think it's the month of May instead of March. Belinda and I share a March birthday, but May is when you celebrate your mothers, right? And I have to go that same theme. I think it's pretty apparent of the women that spoke so far that they had pretty strong women in the you know, that raised strong women. So that's a wonderfully cool thing. And I'm gonna follow suit. My mom was raised 6 kids while she worked full time. You know, she was a dedicated educator. She taught special ed, and education was a really important thing to her, and she inspired that to all of us. She was a woman of great faith, and taught all of my sibs that, you know, the gifts we were given, we were given to share. So I've sort of followed that life suit, you know, under her direction. And she also raised 6 kids where we had to collaborate a lot to you know, get the household stuff done. So I think I learned that from her at around age 2, that was a really important part of being and leading and being professional. And I often tell people who ask that I learned everything I know about leadership from my mom, because she led with her heart. You know, that took priority. And when you do that, it works. So hats off to all our moms. And we can go on to the next person.
Thank you, Kate. I'm going to jump over to Jacob.
Everyone, I'm Jacob Warren. I'm Dean of the College of Health Sciences at the University of Wyoming. So coming to you from Laramie today, where it's going to be 40-something degrees. We're very thrilled that it's not going to be sub-zero. So that's going to be great. And I'm going to continue the tradition. I have to, right? So I have to acknowledge the role that my mother played in my life. She taught me from a very early age the value of hard work and the importance of that. She was a diploma RN and worked her way all the way up to be a very large practice manager in a hospital system, despite having what some would say was, quote, no degree. And so being in higher education, I've always tried to make sure that we don't overemphasize the value of degree over personality and drive and hard work. So that's something that she taught me, in addition to, in her 60s, becoming a CrossFit trainer and a national champion weightlifter. So just a little bit to live up to, right? But I just have to thank her for everything, for showing me how hard work pays off, and that we always need to look at people's assets and strengths rather than what someone might put on a piece of paper about them.
Thank you so much, Jacob. Sharonda? Sharonda, if you're speaking, you are muted, dear.
Yeah, I'm sorry about that. I was trying to start my video and hit the mute button. It was just all going on in the wrong. Let me get my video together.
Instead of going to audit first, go to the client first, but we can't do that.
We can see you now, Sharonda.
Okay. Yeah, I didn't know that at all. Okay, here we go. Oh, you hear me?
We
Did I
can.
hit the mute button? Okay. Ooh, did not hit the mute button. Okay. So I am Sharonda Thompson, and I am a community member. And my motivation, I'm sticking with the theme. My mother. My mother was a single parent. She honestly had her first child when she was 14, and the man should have been arrested, but that's a whole nother time, another conversation. And I was her rainbow baby. She had a miscarriage, then she planned me. So my brother and I are 7 years apart, but she was a single mother. She has mental health issues, had them her whole life. She attempted suicide as a teenager, did not get the help she needed, but somehow she pushed through. She was always, when I was younger, working multiple jobs to make sure that I had everything that I needed, and still somehow was physically there for me as well. You know, I had anything for school, she was there. She always was home to cook meals every night. So even with her working those two jobs, even with her mental health issues, she never skipped a beat to be there to support me through whatever it was that I had going on in life. And so that was a starting point for me. And I always said, okay, well, I'm going to make sure that if I ever have children, I'm going to do better. Like I can't do less than what my mother did. Each generation has to do better. So she was my motivation to do that. So yeah, to me, those were big shoes to fill. You know, be able to completely provide for your children, plus still be there physically and emotionally when they need you. That was a lot. And with her dealing with mental health issues, I can't imagine how hard that was for her, but it never affected me. And so I commend her for everything that she has done. And to this day, I do everything that I can to help her. And that is why I am the person that I am today.
Thank you so much, Sharonda, for sharing your story as well. And we'll get to hear a little bit more from you a little bit later today. Joy?
I'm trying to figure out how to get this going. They might not, oh, there we are. Okay, good morning, I'm Joy, and I heard I've been a pediatrician in Juneau, Alaska for 23 years in a small independent practice, and then last year joined the tribal health organization here, Southeast Alaska Regional Health Consortium, and so now I care for the same kids I cared for before, plus a whole lot more, especially complicated kids. So I'm happy to be on this committee and help do this work. So as soon as you, Belinda said that we're going to be celebrating women or our role models, of course, I thought of my mom too. So it's sort of apt. My mom was young when she married and came from a whole a family with a mentally ill mother, and then married a mentally ill husband, and still persevered. And even though there were lots of bumps and some trauma along the way, she raised 3 children, and here I am. Unfortunately, she developed Alzheimer's and died a little over a year ago, just before she turned 80. And so she's no longer with us, but without her, I wouldn't be who I am and where I am. And be able to do this work with you guys. So thank you.
Thank you, Joy. I'm trying to make sure I'm not missing any committee members. Marie, I know you're just joining us. So this is part of Women's History Month. So we're asking each committee member, as you introduce yourself, to share a little bit about the woman in your life that has inspired you the most and a little bit as to why.
Sure. Good morning, everyone. Apologize for joining in a little bit late. My name is Marie Ramos. I'm a family physician and living in New Hampshire and practicing in primary care, representing, am doing work with the American Academy of Family Physicians around women's health and work on the Commission of Health of the Public and Science as a physician representative. There's so many women that have encouraged me and inspired me in my life. I think most recently, I've been channeling the example that my own mother has brought to me in my life. She was an immigrant coming from the Caribbean. Both she and my father came to America, leaving a very comfortable life in Haiti during the dictatorship in order to create a better future for their family. She was an innovator. She was an empath. She was a visionary beyond what her culture and her in her time expected of women at that time. And she reminded me that no matter one's title, that we must not forget the humanity of others. And regardless of the experience or the impressions that we may have, that everyone is a child of a mother somewhere. And that is what inspired me to become a family physician, to be a family physician that took care of, the whole spectrum of a family continuum, and a family physician that advocates, frankly, on behalf of those that are unable to advocate for themselves, for which I find myself here in this group, to make sure that those who are unborn and yet to be born in the most marginalized communities in our country are seen, are heard, and are given the best opportunity to be the best forms of themselves, and those who birth them. So that's my example.
Thank you, Marie. Have I missed any committee members before I go into ex officio? Make sure we haven't missed anyone. Okay, go into ex officio then. Charlene, are you good to go next?
Hey, good morning, everyone. I'm Charlene Krollinger, and I'm here representing the Division of Reproductive Health from the Centers of Disease Control and Prevention.
Want to tell us about your inspiration?
Sure. I'll just briefly mention my great-grandmother, Margaret Day, who was an inspiration to me as a child. She was a single mom in the 20s and 30s and had a pretty steep uphill climb with my grandmother. She had wanted to get a doctoral degree in library science, but found with a baby she was unable to complete that degree, and so always wished for her grandchildren and great-grandchildren to seek further education. So that really helped me focus in obtaining my degree, and I hope I've made her proud. Thank you, Belinda.
Thank you. Thank you so much. We'll go to Ashley. And if you're speaking, you are muted. I will move on to Wendy.
Hello, everyone. Wendy DeCourcy from the, can you hear me? All right, sorry, thanks. From the Administration for Children and Families, from the Office of Planning, Research, and Evaluation. Looking forward to the new committee season. I'm going to mention among all the lovely ladies in my life, my grandmother, my dad's mom, who was an amazing member of her community, which was an international community, and she really created a unique and friendly and interactive environment there. And I just loved hearing the stories of that. So thanks.
Thank you so much. Amanda?
Good morning, everyone. I am Amanda Cohn. I'm the director of the Division for Birth Defects and Infant Disorders and a pediatrician, and I'm happy to be here. I'm going to switch it up a little bit and say that the biggest inspiration in my life right now are actually my 3 young adult daughters, almost 17, 20, and 20. And I guess they're bringing me so much inspiration now because I feel like there's so many different challenges that they're facing growing up. And I appreciate that they are doing it they bring such an open perspective and really a place of non-judgment that I wish that all of us had been able to experience growing up. And so I'm just really proud of the women they're becoming.
Wonderful, thank you. Allison?
That's funny because I was going to say the same thing as Amanda. I have a 19-year-old and a 14-year-old girl, and I feel like I learn something every single day for how they have navigated, both how they navigated the pandemic and getting to college in such a weird time, and just they are so different than myself in terms of their professional leanings, and they are willing to audition for their jobs every day, which I think is something that we don't all do all the time. And so I actually am inspired by them constantly, and I'm also inspired by their willingness to call me out when I am doing too much and telling me when to slow down, which I don't think I would have ever dared to tell my mother. And so I think I'm very much in Amanda's space because they are really looking at a very different climate than what we grew up in. And they are leading in such an inspirational way. So those are my inspirations. And I didn't say I'm the deputy director of the Eunice Kennedy Shriver National Institute of Child Health and Human Development at the National Institutes of Health.
Thank you, Allison. Yannick?
Good morning, everyone. I am Yannick Edman, and I represent the Office of Minority Health. And currently work on different projects related to maternal health. And so I'm glad to represent the Office of Minority Health on this particular committee. This was a hard question for me, and so I'm going to be very brief. You know, it had me do a whole lot of processing. So not all of us, right, have mothers who represent everything. And so in my life, I've developed mother pies so that I was able to get what I needed at different stages of my life. And so my mother pies is a configuration of strong women, as well as women who did the best that they could, because I feel like Women's Month is not just those who forged their way, but regular everyday women who, you know, dealt with trauma, but still kept going on. So in that sense, I put my great-grandmother, I'm from Haiti, from my village, who was a medicine woman and, you know, raised 7 children and lost half of them because of those conditions. I left my mother, who is an immigrant to this country and brought us here with hope. And then I lived my first grade and kindergarten teacher, Madame Inosa, who as an immigrant child talked in my language and helped me find my space in kindergarten through third grade. And then I lived my godmother as a teenager, who's an Irish nun, who did not have her own children, but showed us how to mother and nurture all children. And so that's my mother pie. And then in college, Dr. Vivian Gordon, who told me that I could become, you know, a PhD like her, and who set the path for my future. And so all these regular women are my inspiration every day, as well as the youth of today, who continue to face battles that we thought we had won and faced it boldly. And so that's my inspiration every day, are those women and the future women that's to come.
Thank you, Yannick. And everyone needs a whole mother pie. So thank you for sharing your pie with us. And last but definitely not least, we'll go to Danielle.
Hi, Belinda. Thank you. So my name is Danielle Ely, and I'm from the Division of Vital Statistics in the Reproductive Statistics branch, and I manage the linked infant death file. And I suppose I also will discuss my own mother, partially because I'm thinking about her a lot right now, because after our meeting tomorrow, I leave for the airport to go visit her for her birthday, as March is her birthday month as well. And she was just always a very steady and supportive person in my life. So thank you.
Thank you, Danielle. Did I miss any other ex officio? And we'd love to hear from the staff, and maybe we'll find time later in the day, because I don't want to leave you all out, but I know we're already a little behind on the schedule. So I'm gonna try to get us back on focus. So any other ex officios? Okay, thank you all.
I think Dr. Warren is on. He's the
Oh,
executive.
and I am looking right at you, Michael Warren, right in the middle of the screen. Thank you.
No worries. This has been so great. And I think for me, it just grounds why this work is so important of this committee, hearing about the impact of mothers and children. And thank you all for sharing. I was fortunate to know, I was reflecting on family. I grew up knowing all 4 grandparents and 6 of 8 great-grandparents. And in fact, many of them lived pretty close. And I had the great fortune of knowing both of the grandmothers and all 4 of the great-grandmothers. So that notion of family really resonates with me. But certainly my mother rises to the top of that. And when I think about her, I think the thing that there's so many wonderful qualities she has. One of them is her ethic of service. And some of my earliest memories of her, one of my great grandmothers lived about 30 minutes away from us. She was widowed, and we would get up every Saturday morning and drive to her house to clean her house and run her errands. And so I remember that from toddlerhood all the way through high school, doing that. I was so grateful when my brother came along, because I didn't have to be the one to dust. I hated dusting, and so I could give him the dusting, and I would do something else. But that was just the expectation she instilled in us, that we did this, and we did it for others who had done things for us. And I saw that whether she was working in the church, or being the leader of the 4-H club, or being on the civic board. This was just always important to her. She worked to make sure that we had opportunities even when she didn't have them. So neither she nor my dad went to college, but she was always insistent that that was important, that my brother and I do that, and that we prepare to do that. She still works full time. She just, in this theme of birthdays, she turned 67 over the weekend, still works full time. She's an office manager for a family farming organization back in Eastern North Carolina. And so I am grateful for her, but instilling that commitment of service and serving others.
Thank you so much, Dr. Warren. Appreciate that. And so I think we got everyone, and again, try to get others in when we have a moment to do so. So I have been asked many times over this last couple of weeks, why did I say yes to being chair for ACIMM? Some people may have thought I bumped my head because there's a lot going on, and what were you thinking? But in reality, I did take time to think about it. I spoke to people that are really near and dear to me. I spoke with the team, and yet, even though I was surprised, to me, it was important. I think that, the group that many that just left ACIMM, with Ed and Magda and specifically Janelle, we spent a lot of time with that version of ACIMM, really trying to elevate the work of American Indians, Native Americans, and making sure that we elevated it to the point that people understood the story, but they were also willing to do something about it. And I don't want us to lose that. But I also think of my own history in public health. I've been doing this for 30 plus years. I started in a local health department in North Carolina in a small community where I had a health director straight out of college that told me I could try anything in that community I wanted to, as long as I didn't get in trouble. And most importantly, I didn't get him in trouble. And so he allowed me to be out in the community and listen to people, to hear the stories and to hear the voices. And I've been able to continue to do that even in my time here in state government in North Carolina. And I think one of the challenges I struggle with, and I think all of us do, is I think people are tired of recommendations. I think our communities are ready for us to move things into action. And I think we need to think, as we're making additional recommendations, our recommendations need to really focus on how do we move the work forward. And so one of the reasons that I said yes is because I really wanted us to be able to align some of our work with some of our national partners. We can make recommendations to our Secretary Becerra, as other recommendations have been made to other secretaries over time, but without the political will, without the boots on the ground, and without listening to people with lived experience that are living this every day, it's not going to move forward. We're not going to be able to move it forward. So I am hoping under this time that we will really focus on actionable things that we can move forward, where people can actually see movement. But I also want to make sure we're spending that time listening to communities, being engaged with communities, and actually trying to address what they view as their top priorities around maternal and infant health. And I think we have started that, and I truly want us to be able to continue to move that forward. So if you all have ideas on how to do this as ACIMM members, please share. I am always open to new ideas. I don't think there is one person that knows how to do all of this. And I think we have a great team here that are willing and committed to move this work forward. And as you will see with all of our agendas, we started this under our former interim chair under Ed. We want to make sure we're listening to people and we're taking that time. So hopefully we will be able to do that more and more with this go round. So at this time, I would like to move to the review and approval of our minutes. So you should have the minutes in your briefing book and in your briefing book from our last meeting. If hopefully.
Motion to move the minutes.
Thank you, Marie. Do we have a second?
I'll second.
Second that motion.
Thank you, Jacob and Sharonda. Thank you both. For those in favor of this motion, if you'll say aye or wave your hand.
Aye.
And hands are waving. Thank you. Any opposers? Any abstentions? Thank you. Then the motion passes and our minutes have been approved. Excellent. Thank you all. And now we're going to go straight into our federal updates. And Michael, we're going to turn it right back over to you, Dr. Warren, to give us an update on what is happening with the Maternal and Child Health Bureau.
Thank you so much, Belinda. I'm sharing my screen. Can you all see the slides?
Yes.
Okay, great. So just a few updates from MCHB, and I want to start by congratulating Belinda again and thanking her for her service to ACIMM. Over the years, she served as a member and as an expert in the field, and now in your time as chair, we are so looking forward to getting to work with you, to learn from you, and to all benefit from your leadership. So thank you for saying yes, and we look forward to continuing this work together. I'm going to spend just a few minutes sharing some high-level updates from the Bureau. As you all are probably aware, the budget for fiscal year 23 passed at the end of last calendar year. a number of exciting increases. Overall, the Bureau's budget increased $127 million compared to last fiscal year. That includes about $823 million for the Maternal and Child Health Block Grant, which includes both the Title V block grant to states as well as special projects of regional and national significance. The appropriations law also reauthorized the Maternal, Infant, and Early Childhood Home Visiting, or MCV program, reauthorized for 5 years, and will double the MCV investment over the course of 5 years. And I want to note this is particularly tied to the recommendations that the committee submitted recently with regards to American Indian and Alaska Native populations. When MCV was reauthorized, the set aside for tribal populations doubled from 3% to 6%, which realigns or aligns with one of the recommendations of this committee. And I'm happy to share that Healthy Start received $145 million, which is about a $13 million increase that is focused on reducing and eliminating disparities in maternal and infant health outcomes. I'm going to talk about a few specific funding opportunities that are related to maternal and infant health. We saw increases across a number of lines, so a $3 million increase in the Alliance for Innovation in Maternal Health, or AIMM project, a $3.5 million increase in screening and treatment for maternal mental health and substance use disorder. This is the state teleconsultation program, a $26 million increase in state maternal health innovation grants, $3 million for the new maternal mental health hotline on top of the existing investment, and then nearly $3 million in new funds to address sudden infant death syndrome. There were also several items that received funding for the first time. So there was $10 million to create research networks with minority serving institutions, and $10 million in new funding to support integrated maternal health service demonstrations. So this includes demonstration projects that would replicate models like the pregnancy medical home and be able to test those and have those go to scale. Several of these are now out on the street. So we recently have posted funding for AIMM capacity projects. We're expecting to fund around 29 of those at $200,000 each. This is a great opportunity for states and jurisdictions to be able to get basic support to be able to advance the work of AIMM in their states. We'll also be funding one technical assistance center at a national level to support this. I do want to note that the funding deadline is May 9th on these. Typically in the Bureau, we like to have a 90-day application window because of the timing of the budget this year. We weren't able to do that. So these are on the street for 60 days and that clock is already ticking. So I encourage you to make sure that your networks are aware of these and meet that May 9th deadline. We also, the funding opportunity for the Integrated Maternal Health Services Project is open. We anticipate making 5 awards at about $1.8 million each. Again, these are those demonstration kinds of projects that would replicate models like pregnancy medical home to be able to show improvements in maternal health outcomes and reduction of disparities. So these are out on the street now. I do want to make you aware of a number of other ones that are going to be following very soon. We hope anytime now for some of these. The Maternal Health Research Collaborative for Minority Serving Institutions, I mentioned that. We anticipate making 16 different research network awards, as well as 1 award for one coordinating center. We hope to get those funding opportunities posted later this month. We will also be competing the Screening and Treatment for Maternal Mental Health and Substance Use Disorders program. Previously, we had 7 states funded under that program. We anticipate making up to 14 awards with this new iteration of the program, and that funding opportunity should post later this month. We will be competing new state maternal health innovation awards. We've got a number of states that are already participating in this. For some of them, they're reaching the end of their performance cycle, but we also, with that significant bump in the budget, will be offering new awards. So we anticipate over 20 awards to be made, up to $2 million each, depending on the work that they're doing. And then we're very excited to be able to compete a new round of funding for Healthy Start. The whole of the Healthy Start program will recompete next year in fiscal year 24. So stay tuned for that. But we did get new funding to support about 10 enhanced projects that are looking at the core work that Healthy Start does, but also thinking about social and structural determinants of health and those drivers of poor maternal and infant health outcomes, and in particular disparities. And in particular, as was noted in the president's budget proposal, getting in those communities that have the highest number of excess infant deaths. So really going to places where the need is great. Lastly, we'll be competing a national home visiting workforce development center. This was included in the reauthorization. Part of that includes the Jackie Walorski Center for Evidence-Based Case Management, and we anticipate that being released in early May. So the team has been incredibly busy drafting these funding announcements that we call NOFOs. There will be a lot of work going on by our state and community partners over the next few months, and preparing applications and submitting those. And then all of these will be awarded by the end of the fiscal year, September 30th, which seems like a long time away, but it will be here before we know it. So wanted to make sure that all of you were aware. We've been trying really hard to get these out so that folks are aware of them, particularly because the timelines are tight. We just did a webinar last Thursday with stakeholders. We had 500 folks on the webinar to hear about these funding opportunities. So I think there is a lot of interest and appreciate anything you can do to spread the word there. Lastly, I just want to share with you some work that we've been doing. There's a lot going on, but just a couple of highlights. We've recently completed a request for information process on Healthy Start. As I mentioned earlier, the entire Healthy Start program will be recompeting next year in fiscal year 24. And we wanted to understand from the field broadly how things are working, where folks might have feedback on the Healthy Start program. So we specifically put out a request for information, hoping that we get feedback from grantees, community members, people with lived experience, healthcare providers, community health workers, birthing people, parents, and other members of the public. And the goal is that this would inform future iterations of the Healthy Start program. We got over 100 responses for that RFI, and some of the broad themes that came up included increasing the emphasis on how Healthy Start programs might address social and structural determinants of health, and in particular, the need to have multiple strategies to be able to do this. A theme around supporting Healthy Start programs to address racism and bias in healthcare through education and training, family engagement, and cross-sector partnerships. A theme around considering the needs of rural and border communities in Healthy Start program design, a recognition of the value of a single Healthy Start database and challenges that switching to new databases may pose for some grantees, and then other related suggestions around the data collection system. So our team is compiling those for considerations as we think about, again, that next iteration of Healthy Start. And that notice of funding opportunity will be posted as we move into FY24. Lastly, I just wanted to share with you that at the end of last calendar year, we released updates to the Women's Preventive Services Initiative guidelines and our Bright Futures periodicity schedule. As you all know, in the Affordable Care Act, we are tasked with supporting these guidelines as well as the newborn screening guidelines through the recommended uniform screening panel. In particular, on the women's preventive services, there are updates related to diabetes screening during and after pregnancy. And as you all know, once the guidelines are accepted by the HRSA administrator, within a year from that, insurance companies are required to provide coverage for those preventive services without cost sharing. So this goes a long way as we think about improving access and improving equitable care. So the coverage for these most recent changes will go into effect starting January 1st, 2024. That is it for me. Please don't hesitate to reach out if you have any questions. And I know we're going to be sharing some updates over the course of the next couple of days about our work across the federal agencies with respect to the recommendations the committee shared regarding American Indian and Alaska Native populations. So look forward to that. And with that, I'll pass it over to my colleague, Dr. Allison Cernich.
Great. Thanks, Michael, so much. So thank you for pulling up my slides. I appreciate that. So I was asked to just give an update about what is going on at NIH and specifically at NICHD in the areas that are covered by this committee. So I want to thank Vanessa and Michael and team for welcoming me with this update. Next slide, please. So the first thing I just want to make sure everybody knows about is our NIH-wide initiative called Implementing a Maternal Health and Pregnancy Outcomes Vision for Everyone. If you can go to the next slide, please. So our Improve initiative, this is an NIH-wide effort, and we're really focused on reducing preventable causes of maternal deaths and improving health for women before, during, and after delivery. We have a major emphasis as reflected in the most recent maternal health numbers, specifically our maternal mortality numbers. We continue to have an ongoing crisis in communities of color with respect to maternal health, especially in the Black community and the American Indian Alaska Native community. And so we really are thinking about those communities as well as communities that are disproportionately affected. So for example, those that are in maternity care deserts. So we started this, we received a new appropriation in FY22. So in 21, we had started this just sort of organically to respond, and we had put together $13 million across NIH from our own base appropriations to think about maternal health. We included the impacts of COVID-19 on maternal health, as well as structural racism and discrimination in the context of COVID-19. We were able to fund a number of grants in this area and recently hosted a workshop last week on some of the awardees that received funding, which was absolutely incredible to see some of those results moving forward. In FY22, as I mentioned, we had a new appropriation. And so what we were asked to do in the president's budget and also by our sponsors from Congress was to really concentrate on ways to get evidence-based interventions in the community and to establish maternal health research centers of excellence. And so what we have done in this program is established a number of different streams of work. So the centers of excellence are our core. They were announced last year, and we are getting close to awarding. We had a really robust response to these requests for applications, and it includes a coordinating center that will focus on dissemination and implementation research, a data coordinating hub, and also some data methodology hubs that will support up to 7 centers of excellence across the country. We also have funded a number of other novel things in FY22. So we put out a notice of special interest for projects on dissemination and implementation research to advance evidence-based implementation of evidence-based practices for maternal health. And we've received those applications, and those will be reviewed very soon and awarded this year. We have funded through the National Heart, Lung, and Blood Institute community implementation programs. Those are under a new kind of award, which is another transaction authority. So these are collaborations between academic centers and community organizations to bring evidence-based care into communities. And we should be funding 2 to 3 of those collaborations this year. We're also working with the Office of the National Coordinator to do standards for the electronic health record. And so we are working to pilot some things that we have done to bring these standards to bear. This allows researchers to use health record data for real world research. And so we are trying to establish that as a core set for those of you who are familiar with these standards, USCDI and USCDI Plus. They're common data element sort of approaches. And that is what we're working with the Office of the National Coordinator for Health Technology on. We have also sponsored 2 challenges under a prize authority. So the first is to drive technology, either point of care technology or in-home technologies. So we are using the same framework that NIH used for COVID diagnostics. So if you guys remember that sort of Shark Tank approach, we're doing that with a number of technology companies to get either at home of point of care diagnostics for maternity care deserts in place to detect risk for people who are pregnant. And then we also have a community partnership challenge, and I'll update on this, but this is a challenge where we're actually not funding academic organizations. We are working with community organizations that are looking to build a research infrastructure, and we're providing them training and mentoring. in how to move into the research space. And so we are in an exciting phase of this challenge right now. So if you go to the next slide. So recently we awarded prizes to 15 organizations. So we had about 86 organizations come in and get some initial training on how they might build their research infrastructure. Each organization received $10,000 and an invitation to participate in the proposal phase. So we're working with these 15 organizations. They're getting one-on-one mentoring as well as webinars every week to talk about how would you go about building a research piece of your organization, proposing for grants in the federal space. What would you need to think about? And then in the next phase, those who advance, we're going to have 10 organizations advance. They will receive a prize and they will then be invited to conduct their research. And at the end of that, there will be a final prize for those organizations. And so we're actually looking forward to building some research on the ground research teams through this challenge. And it's been really great to see communities that are really underrepresented building research in the field where they have some experience, but they really just need some mentoring. As I mentioned, RADx Tech for Maternal Health, we had 15 organizations that were announced as the winners of the viability assessment phase, meaning they've gone through a number of commercialization, scientific, as well as sort of a usability look for some of their technologies. And actually, I think some of them has also participated in our sister organization, HRSA's initial prizes. So they were kind of ready to go here. And so it's a great way that we could see some translation. And so now we're in the deep dive assessment phase. They've received $20,000. And so we're trying to move some technologies forward relatively rapidly. And so, yeah, and I'll put the website in for the connecting the community for the 15 organizations that were announced as the winners for sure, Belinda. So I said the others were in review. So that is our Improve initiative. Next slide, please. The other thing that we've been working a lot on, we had been asked to establish a working group to produce recommendations for the federal government to address stillbirth. Next slide, please. And so we know that stillbirth is a major issue in the United States. We have so many families that have been affected by this, real tragedy where, people are being, confronted with their carried a pregnancy almost to term or to term, and then they are either asked to deliver or have an emergency C-section to deliver a child that is not alive. And so we have been working with a working group of our council on this. We had 4 working group meetings that were held from 2022 to 2023, thinking about the different ways that we could address what was being asked for us by the Congress, meaning, what is the scope of the problem? What are our current barriers to collecting data? Who is at risk? What is the psychological impact? And also, who is at risk, including communities at higher risk? And then how do we need to treat mothers after stillbirth? And this is something that we really need to pay better attention to, specifically for the psychological impact. We heard from many families in our meeting in January about the long-term impacts of a stillbirth on the family, the effects it has on subsequent pregnancies or even subsequent desire for pregnancy, as well as not just on the immediate parents of the child, but also the extended family, and the need for fetal autopsies, the need for really a reason for that death is such a central need for many of these families, and we do not cover this right now. We put also out a request for information that was published in November, and we received responses through that. Next slide, please. So last week, we published our recommendations, and I want to thank my federal colleagues also for their tremendous work as ex officios on this group, because they also assigned themselves work, and we truly appreciate it. But we presented the initial findings at our National Advisory Committee for feedback discussion, and then the report was published last week. And so essentially our recommendations are fourfold. One is to improve the quality of vital statistics, surveillance, and epidemiologic data on stillbirth at the local, state, and national level. to think about how to use those insights as well as from clinical data to think about disparities and identify prevention opportunities, to conduct implementation research to help develop culturally sensitive interventions to support families that have experienced stillbirth, and for us to establish a research agenda for risk factors, mechanisms that surround stillbirth, as well as definitely other ways that we can prevent stillbirth. So we are going to be starting to implement some of these recommendations, but we've also received additional language from the Congress related to other areas where they would like recommendations. So we will be continuing with this group to work on stillbirth. So more to come here. Next slide, please. The other thing that some of you may have been aware that we did a while back is the Task Force on Research Specific to Pregnant Women and Lactating Women, otherwise known as PREGLAC. Next slide, please. So we originally started this work in 2016 as part of the 21st Century Cures Act, and we really were trying to address knowledge gaps regarding safe and effective therapies and vaccines for pregnant and lactating women. And we had great representation not only from our federal partners, but we also had our professional societies, industry, academia, and nonprofit organizations, and NICHD was the lead for this. In 2018, we provided 15 recommendations to the Secretary about how to promote the inclusion of pregnant and lactating women in clinical trials. And after that, the Secretary extended the charter and they wanted us to move towards implementation recommendations. And so we published those implementation recommendations in 2020. And we have been working on this ever since. And so we are really thinking about in this work how to protect women through research rather than from research, because we know that some of the we make decisions based on information, and if we don't have information, it's very difficult to make decisions. So the next slide, please. So what we've done to start implementing at the NIH level, and this is through NICHD, is we've established the Imprint Hub, which is advancing frontiers in health through maternal and pediatric precision and therapeutics. And so what this did was it established both the Knowledge Core and Centers of Excellence. We have 2 centers of excellence at the Universities, California, San Diego, and Vanderbilt, and then a partnership between Indiana and Ohio State, which serves as the central coordinating center for that entire hub. And they're thinking about how to conduct and foster therapeutics-focused research in obstetrics, lactation, and pediatrics. And they also want to include people with disabilities as part of this. It also addresses the underrepresentation of women and children in clinical trials. So we're thinking about how to make the knowledge available, the regulatory science behind this, and also drug development tools that we can use to accelerate this work, and really hoping to facilitate safer, more inclusive, and more cost-effective trials. So a couple of examples, we're looking at the effects of maternal antibiotics on breast milk and infant outcomes. We're looking at electronic health records as a way to phenotype how pharmacogenomics works, excuse me. And we're also thinking about how to use real world data for things like neonatal opioid withdrawal syndrome. And so these are just a few examples of what the Imprint Hub is doing. And I think this is going to be a really exciting program moving forward. Next slide, please. And we continue to do our work too globally. So NICHD is one of the largest sponsors of work in this area in maternal health in the international space. And our global health network has been working with the Bill and Melinda Gates Foundation. We just recently published a transformational trial looking at whether single oral 2-gram dose of azithromycin could reduce postpartum sepsis and death. And the study actually was really successful in enrollment. We had 29,000 women in 7 low and middle income countries in the study, and it was stopped because there was a clear maternal benefit. It reduced by 1/3 the risk of postpartum sepsis and death. Now, we did note that it did not reduce the risk of stillbirth, newborn sepsis, or newborn death, but for maternal health, it had a very significant impact. So we stopped that study early, and those results were recently published with a citation there. Next slide, please. And so to continue our work in this area and looking at the effects of therapeutics in pregnancy and lactation, we have been asked now to recreate an advisory committee to monitor and report on the implementation recommendations from PREGLAC. And so we are going to reconstitute this likely as a working group of our council this year. And we've been working with the Office of Women's Health and HHS, and we will again include our partners here to start this committee to monitor our implementation efforts. Next slide, please. And just a couple of other updates. Next slide. Just to let you all know, we do have two major networks that we do research through. One is the maternal fetal medicine units, and the other is the neonatal research network. And so we're hoping to announce the awardees for these networks very soon. But we did change the structure of these networks. They've been around for a really long time, and they're one of the biggest catalysts for clinical practice recommendations. But we're hoping to broaden and diversify the groups of investigators who can propose projects to use the network. We're also thinking about how we enhance review and approval for this. So we will be reviewing protocols in a different way to make sure that we have the standards that we need for rigor and reproducibility. And we will be reviewing those protocols through scientific review. They used to go through the networks themselves, and we're bringing them back to the NIH level just to make sure that we have some input, because these are cooperative agreements in terms of the science that's being conducted and ways that we can make sure that we're including diverse populations, as well as making sure that the science is of the utmost quality, because these are major investments for us. Next slide, please. So with that, I will close. And I'm happy to answer any questions in the chat. I'll wait on Emmy for now, but thanks.
Thank you so much, Dr. Warren and Dr. Cernak. Does anyone have questions? We'll take a quick moment and try to answer one or two. Yes, Tara.
Hi, just a quick question. Thanks, Allison. For the PREGLAC, I was really interested in what you presented there. And when you're looking at therapies, are you also including opportunities that women might have for fetal surgery? Are you going that far? Because I mean, like CHOP is a major hub for offering fetal surgery, like women that with their baby finds out that they have spina bifida or something like that, twin to twin. So just wondering how broad are you looking when you start talking therapies?
Yeah, so PREGLAC is really focused on pharmacotherapies, Tara, but we were the major sponsor for the studies that looked at spina bifida repair prenatally. So we do engage in that research, and it could potentially be a part of the networks if that was thought to be an area of scientific focus that we wanted to pursue, that those networks might be a perfect place to propose a surgical trial through the MFMU or through the NRN, but we can also sponsor those trials through our regular mechanisms. But the MOM study was one of the major interventional studies that we did to look at the efficacy of those surgeries. So it's within our purview, but not a focus for PREGLAC. PREGLAC's really focused on pharmacotherapies.
Excellent. Thank you so much.
Does anyone else have a question?
I do.
Yes, Sharonda.
Okay, so for someone that's not in the medical field, what's pharmacotherapy?
That is a great question. So drugs.
Okay.
So medications so a lot of the medications that are used during pregnancy, interestingly, have never been studied in pregnancy. And so drugs like those that we use to treat depression, epilepsy, common conditions that people have going into a pregnancy often have not been studied, both on their effects during pregnancy on the mom, as well as the effects during pregnancy on the fetus. And so what we are looking at is safety and efficacy and label changes that we could support research on to tell, not only providers, but also pregnant people about what risks that they're taking on, both for treatment or without treatment, and also how the drugs behave differently. As you know, women's bodies undergo a lot of changes during pregnancy, right? And so the way that drugs are essentially behaving in the body, those change as well. And so what we're trying to do is study some of that to see, does the dose change? Does the duration of the dose change? Does the, those sorts of things are pretty important for people to understand when they're trying to make a decision about, do I keep on this antidepressant or do I not? Is it better for me to not be depressed during my pregnancy and take this medication? Or is it better for me to go off this medication because it's safer for my child, or use a different medication that may be safer and more effective? So that's what we're talking about. Thanks for the question.
Thanks, Allison and Sharonda. Thank you for keeping us on point. Sharonda, did you have another follow-up?
I would, does that include, I know you said during the pregnancy, so does this mean this is a study that's already been done to see if it passes on through breast milk?
So that's the
Or
other
is it-
reason that we're doing pregnancy and lactation. So we are looking at whether and how much of a drug goes into breast milk. And we have a number of studies. We have a really interesting study that's looking at multiple medications at the same time. So they're studying breast milk in people who are already coming back for visits, and they are getting samples of breast milk, samples of maternal blood, samples of infant blood, to see what the transmission is through breast milk of a number of commonly used medications. So that study is underway now. It's called the Cuddle study.
Okay, thank you.
Thank you. I don't see any other questions though. Michael, for all of those grant awards that are coming out, are they all 5-year awards? Or there's some variation?
There may be some variation. I have to go back and look. We generally try to do 4 or 5-year awards, but let me go back and look at that list specifically to make sure I'm not misspeaking. What we can do is we can put the link to the grants.gov site or our MCHP funding site, and folks can go, because in that notice of funding opportunity, they'll all be listed there. I was looking down the list to see. Let me double check because I don't want to misspeak. Generally, they are, but I don't want to misspeak for all of them.
Understood. Thank you so very much. And thank you, Allison, for dropping in the chat the winners for the community version of it. So that's really exciting. So at this time, we're going to go on and continue with our agenda. And I'm going to turn it over to Vanessa and to Sarah to talk about the ACIMM charter renewal and bylaws.
Thank you, Belinda. Hello again, everyone. And did want to introduce my colleague, Sarah Meyerholtz. She's the new ACIMM program lead in our Division of Healthy Start and Perinatal Services at MCHB, where I work. So before I turn it over to her to help walk us through some of the changes that happened in the last 2 charters, just want to give everyone a quick update on what's going to happen this year. So if you did have a chance to look over the charter, you'll see they expire every 2 years. So this current charter that we're under right now will expire September 30th. And so Sarah and I are working towards submitting the package of paperwork to renew the committee's charter in June. So we knew the June meeting would be a little too late to ask you guys for feedback. So we're presenting it now at the March meeting. And as we did 2 years ago with Ed and the other committee members, we wanted to take some time to hear your feedback and input into the charter, as again, we plan to renew it. The key areas that most of the time the members are most interested in are obviously the committee's objectives and scope, what your duties are, and the memberships section of the charter. That's where the ex officio agencies are listed. So just want to point you to those areas if you're sort of time limited, but we welcome feedback and input on any parts of the charter. Like I said, Sarah's going to walk us through what has changed in the last 2 versions of the charter, just to see if there's any new changes that are needed, or if you guys think, hey, there's been a lot of work already, we're pretty good with how things are. The other last thing I'll say before turning it over to Sarah is that ultimately this will be HRSA and HHS's decision. So we can't guarantee that the feedback you send us will necessarily be incorporated, but we still welcome it. And last time, I think the majority, if not all of it, was actually taken. We got really good input from the committee members. But again, just no guarantees that it'll ultimately be HHS's decision. And then this is not your only chance to give us feedback or input. We will take your thoughts after the meeting. I think we talked to Belinda about having committee members send her any thoughts or ideas, suggestions you have for the charter, and she'll compile it all and send it to Sarah and I. And we will give you guys, I think we said about the next 30 days. So you'll have a month to sort of digest and process what we're sharing today, read through things, ask us questions. And then again, ideally, we'd get your feedback in the next 30 days or so, just so we have time to prepare that package for submission in June. Sarah, is there anything you want to add before you walk us through the charters?
I don't think so. Yeah, thanks, Vanessa. I'm happy to go ahead and share my screen with our first charter. So 2019 to 2021 is the first one I'll be pulling up. This was included in your briefing book, and you should be able to see it now.
Yes.
Excellent. So what you may have seen in this particular charter was that it demonstrates the trends in growing maternal mortality rates. And you can see this, how it's further fleshed out, these addressing maternal health outcomes, especially in the objectives and scope of activities. You'll see more of a focus on improving maternal health outcomes, including preventing and reducing maternal mortality and maternal morbidity. So this is a change from the previous charter, the 2017 to 2019 charter, which was more focused on infant mortality. Moving down just a little bit in section 4, description of duties. Again, this just reflects that further focus on maternal morbidity and mortality, and further reflects the description of duties by the committee to provide recommendations to the secretary in both infant and maternal mortality. And I don't want to make you too dizzy, but going all the way down to the bottom, there was no changes from 2017 to 2019 to this this charter of 2019 to 21 that I'm showing now, except for this one last little sentence at the end in subcommittees, just describing how subcommittees operate within the context of the broader ACIMM committee. So this is the 2017 to 2019 charter. I'm going to switch over to the 2019 to 2023 charter, the charter that the committee is operating under currently. And we'll walk through the changes from this one, the 2019 to the 2021 charter. So most exciting, you'll see that the first line here, the official designation, really calls out that maternal mortality. And as the committee is known today, the Advisory Committee on Infant and Maternal Mortality. So that was a big change from the previous charter. In the objective and scope of activities section, these updates were suggested by the former acting chair and committee members and really reflect the priority areas of further addressing social and structural determinants of health. And in the description of duties, you'll see that these were edited to just really reflect what had been updated in the scope of the work to be further outlined here. The Title V MCH Block Grant Program was also added within the description of duties because it had not been previously, and that is the largest MCHB investment, as well as the Healthy People objectives. Healthy People 2030 objectives were always included in previous charters, but it was called something different before, so it was further clarified in this current charter that we are operating under now. Moving on down to section 8, regarding the designated federal officer, or Vanessa, as we all know and love. Just a brief sentence here was added in the most recent charter to describe what would happen with the committee operations in the event that she's unable to fulfill any duties. And as Vanessa noted, I am now the part-time support to the committee, so very excited to be working with everyone here, especially Belinda as our new chairperson. Moving down to section 9, there was a small adjustment here to the number of meetings per year. Historically, I think it was 2 meetings per year, and Vanessa, correct me if that's wrong. But the committee wished to provide the option for more opportunities to convene each year because there's just so much work to be done, and it's difficult to continue these discussions that need to be had to create these wonderful recommendations and actions if there aren't more times to do so. Moving down, finally, the last update from 2017 to 2019 to this current, I'm sorry, 2019 to 2021 to this current charter, 2021 to 2023 is in the membership and designation section, number 12, which clarifies that the ex officio members that you heard from this morning are non-voting, and a representative from the Substance Abuse and Mental Health Services Administration was added. That had not been included previously. That is just a very high level overview of the changes that were made from the previous charter to the current charter. So we do want to pause here and just ask if there's any initial feedback, thoughts, comments, questions that you'd like to provide to us now. And like Vanessa said, you do have the opportunity to reach back out to us. We're happy to meet and talk about it. Whatever works for you. We do ask that you share your feedback with Belinda, who will then collate everything and send it to us by April 20th. But we are here right now if you have anything else to share. And Vanessa, anything that I missed, I'll stop sharing so we can see each other.
No, that was a great overview. Thank you, Sarah. I think you hit all the highlights of, again, what the feedback and types of changes we've made in the last 2 renewals. Thank you.
I just have a quick, oh, sorry.
Oh, go on. No, go on, Tara. I was going to see if anyone had questions.
Sorry, yeah, just a quick question. When I first joined the committee, I know at the time, I mean, I was told that we would be meeting about, twice a year. And then that changed. I guess my question, since I wasn't a member of the committee for very long before it changed to 4, do we have any like stats or outcome measurements to say whether, was a lot more work done with meeting 4 times a year? Do we feel like this is working? It's a good use of time and government money and resources. So I'm just wondering, like, what are people's thoughts on that?
Yes, and
I'll
as
just chime in, but Vanessa, because I will say that just before you came on, Tara, we did feel the need to do more meetings because there were things that we wanted to make sure we were following up in between, but also it gave us more opportunity to get other presentations and have conversations about the issues that were on the table, and they were so critical. So I think we felt like twice a year, it was just a long ways in between, trying to follow up on the different recommendations and the things that we were moving forward. But I don't know, Vanessa, if you were going to say something.
Yeah, just that. Thank you, Belinda, and good question, Tara. And I think we are definitely open to your feedback and thoughts and input on how many times, and it doesn't have to be super precise. We can say, up to or approximately, as we did with this last one. I will say I did notice that with this sort of group in the last 2 years, there's been 3 sets of recommendations that were submitted to the secretary. So you started with the ones looking at COVID and the impact on maternal and infant health. And then you had the other recommendations, mostly around workforce, migrant, environmental conditions. Those were August of 2021. And then you had the 2022 recommendations focused on improving birth outcomes of American Indian, Alaska Native. Prior to those 3 sets of recommendations, the last I could find, on our website were back in 2013. So I think that to me just demonstrated there was definitely a lot of work that you all did, or the previous group as well. Again, not to say it's still needed. I don't know what the right maybe number of meetings is, but I will say, I think in terms of recommendations and those as an output of the committee, there certainly was a bump up.
Yeah, that helps. Thank you, Vanessa. That's a good point.
Any other thoughts? If not, if you'll take the time to just review them in detail and then send me any recommendations, any edits, any changes that you would like to see move forward back to the Bureau. If you'll send it to me by April, what do we say, April 20th.
Mm-hmm.
And we'll send out a reminder.
Yes.
Just to be on the safe side. Okay. Now, so Sarah, anything else that you all were going to add? Thank you so very much. So we're now down for a break. We're scheduled to come back at 1. Let's plan to come back at 1:15, and then we'll shorten. I'll work on during the break time to try to shorten this frameworks conversation. So I think we'll still be on track with our time. So if everyone could plan to come back at 1:15 Eastern time, and then apply it to whatever time you have. And we'll see you in a little bit. Thank you all. So I am showing 1:15 on my end. That was quick, but hopefully you all were able to at least take a short break. If it's lunchtime where you are, grab a bite. And if you need to be off camera to keep eating it, we definitely understand. Well, some of you may be eating breakfast now. So we're going to follow back through on the agenda, and now we're going to go into our follow-up recommendations to improve American Indian, Alaska Native birth outcomes. We wanted to have this session specifically so we can follow up on what has been going on with the recommendations, the last group of recommendations that we made to the Secretary. We did reach out to Ed, our former interim chair, as well as to Janelle and to Magda to get some feedback from them. I think some of it they sent out to you all, but others they may not have. But I did want to just kind of share a little bit about what I've heard from them. And then we'll go into our own discussion and say what the rest of us have been doing related to this work. I know Janelle is planning next week. She will be presenting on these recommendations as part of her presentation with the National Healthy Start Association's spring conference. I know she will be there next week. So I know that is one of the things that she is focused on, not to mention numerous other speaking engagements that she's been invited to continue to elevate the work and the work of those recommendations. Ed did share with us that he had been working, Janelle, as well as Magda. They had authored a commentary piece that was recently published in the Minnesota Post. And so he did share that link with the committee, so you all should have it. Time to Make Amends, Improving the Health of American Indian and Alaska Native Mothers and Infants. So he did share the link. If you've not had a chance to look at it, please take a moment to do so because it was a very well written piece as we would expect. Ed also shared dissemination efforts that had gone on. Otherwise, that, a letter had been sent to kind of the heads of like AMCHIP, the National Healthy Start Association, City Match, ASTO, NICHQ, and many other entities in the public health field. They had been sent a copy of the report for them to share with their members and specifically have conversations with their boards. APHA had a webinar where it was mentioned more recently for State of Public Health. We know Dr. Warren has mentioned it on several maternal health webinars. We also know that Ed did a presentation for all state health officers on our ASTO All State Health Officers Call. And a similar presentation was made to the ASTO Healthy Babies Subcommittee. ASTO is also planning a podcast focused on the report. And then there are numerous other areas. Plans are being discussed for a session of the report at an APH annual meeting, as well as with the City Match Conference that's coming up in September. A journal article is being drafted with hopes of a publication for JAMA. As well as contacts are being made with the Association of School and Programs in Public Health, Equity Curriculum in member institutions and other places. Magda was able to share a few things as well. She's been working again with the City Match Board to make sure that it is included in their work and their ongoing efforts. They're also exploring a symposium again for City Match, MCH EPI in September on translating making amends into actual actions. So excited to hear about that, as well as the National Center for Fatality Review and Prevention Strategic Storytelling Learning Collaborative is using this report in its team-based leadership and capacity building initiative. And so again, it's an example of strategic storytelling for policy change. So the work that has happened with this last report and others, this is just one iteration, continues to move forward. But today we want to hear from everyone else, to talk a little bit about what have we been doing with the recommendations from the last report since we met in December. So just a couple of questions for everyone, so everyone can get ready to try to chime in. And if you haven't done anything, talk about what you plan to do. So we go either direction. So what members specifically has been done around spreading this report since December? That is basically the first question. And then the second question we want to roll into right after that is, one of the things we keep saying around the work that we are doing is we want to make these recommendations, we submit them to the secretary, but what does accountability from the department look like from the committee's perspective? When we submit them, really in reality, what are we expecting from our recommendations? Are we expecting them to immediately move them into implementation? Are we expecting them to provide us a regular update? Specifically, what are we thinking accountability is? And then what else needs to be done to move these recommendations forward? So we'll leave the questions up on the screen so everyone can see them. But I will take time now to see if there are committee members that would like to chime in on any of these areas. Thank you, Maria. Marie.
Thanks, Belinda. Yeah, so a lot of work has been done over the last few months on my behalf. I've shared this article with the New Hampshire Endowment for Health to help with cross-collaboration discussions within the state health department, as well as the state health assessment, health improvement plan advisory council, which is governor directed. I also have shared this with the American Academy of Family Physicians, and they shared this material to its members and made a particular focus within the maternal health member interest group. I'll be working on a collaboration CME project on fourth trimester for women and infants, and in part of my particular presentation, we'll be discussing different aspects of cultural sensitivity regarding fourth trimester and including some of the references from our piece as well as it relates to Indigenous practices. We've done some work as well with national Indigenous organizations for the American Academy of Family Physicians as well, enlisting our Indigenous members within the organization to provide additional support and to provide additional resources for current members on Indigenous practices and considerations for their particular populations of service. Within the value-based care spectrum, a lot of discussion on health equity surrounds community health centers, so rural health centers and federally qualified health centers, but it's very rare to discuss Indian health services and how value-based care, alternative payment models can be incorporated in order to help expand resources for those particular communities that Indian Health Services takes care of and represents. So those are a few areas that I've been working on personally. I'm looking forward to doing some cross-collaborative social media pieces and joining on some podcasts as well to talk a little bit further about the project.
Wonderful, Maria. Thank you so much for sharing. Sherry, we'll jump over to you.
Thank you very much. I have also shared it with various organizations. I've shared it with the national nonprofit organization, the 0 to 3 Policy Center, who advocates on the Hill and supports families, provides resources to families as well through briefs and other family resources, as well as is in contact with other organizations that have similar interests and missions and goals. I've also shared it within the American Academy of Pediatrics, specifically the Council on Early Childhood, which is charged in part with writing policy statements that are very widely received across the country by multiple early childhood professionals, and with the Council on Healthy Mental and Emotional Development, which is charged with education and advocacy and promotion of the health and well-being of all the pediatric population. I have shared it with Oregon's Maternal Child Health Division and have received word back in one instance that they are looking at how it can be implemented within the home visiting program in the state. And I have also shared it with multiple early childhood leaders within the state as well, across discipline early childhood fields.
Wonderful, great sharing and making sure that the word is getting out. Anyone else want to share how they've been able to elevate the work and move it throughout their community, their state, their national affiliations, or what you plan to do if you've not had a chance to do anything yet? We'll say in no, oh, go on. Go on,
yeah.
Tara.
So, no, I'll just, I just think, it's such important work. And whenever, I interact at the legislative level, because we're involved in science policy and in any measure that's going to involve measures of health for women and infants and the unborn, and so moms and babies. And so anytime I interact with legislators, either at the state or the federal level, I make them aware that, we've been involved in this work and that they need to consider what we've written in the report, especially within the indigenous populations. So just want you to know that definitely it's definitely in multiple conversations, and plan to continue those conversations and share the work that's been done.
Great, thank you, Tara. Go on, Phyllis. I see you coming out from mute.
Yeah, being a very new member, I have developed a list of nursing organizations and leadership that I plan to send to, because nurses are 80% of the healthcare workforce, and we have several professional groups that are really focused on women's health. But I did reach out to Ed to see if there was a template or a suggested wording when you contact individuals formally with the link, because I don't want to misstep. And so he said there is none, but if folks have used a letter or an introductory email, I would appreciate seeing something like that. Just I don't know if there are what are their limits or how we say things without being making sure we're not saying the wrong things. Thank you.
Understand, Phyllis, and I can share something with you if you don't hear from anyone else, because I have shared it in a couple of places myself. And I see Sherry, you've dropped something else in the chat. You've also shared it with the Alliance for the Advancement of Infant Mental Health. Wonderful, thank you, Sherry. I know in my own state, I shared it with our Commission on Indian Affairs, as well as our Office of Health Equity, not to mention the folks within our state Title V entity, making sure that they're all aware. And then I made sure I had a conversation with the board of the National Healthy Start Association, sharing it with them, as well as with the board of the of AMCHIP, the Association of Maternal and Child Health Programs, but have plans to make sure that it is distributed more widely, especially within my own state, through our provider support network, through some of the work that our Perinatal Health Equity Collective does. And so looking to have future presentations there so that they can see that the work, how it impacts the work we're doing in North Carolina. Yes, Jacob.
One thing I've been working on is getting it disseminated within rural health networks. So that's my particular background. So how we're working with rural agencies, because of course they're not one and the same, but there is a significant amount of overlap. obviously. So that's been one element, trying to get that out in National Rural Health Association and other organizations that focus on rural in particular. And then locally here in Wyoming, I've been working with one of the tribes to look at how we can, again, translate this into action, and how we can work together to develop an advocacy approach that they can use as this particular tribe took over their own health services from IHS. And so they're able to be a lot more nimble in what they can implement. And so that's part of what we've been doing here in Wyoming.
Thank you, Jacob, for sharing that, and specifically also for bringing up rural health. That is one of the other areas that I need to reach out in my own state with the Office of Rural Health. We work with them on numerous efforts, and I just have not shared this with them. So thank you for the reminder. Hey, if no one else has anything to share, you can always drop it in the chat. But the other part of the conversation is the accountability question. So once, we've submitted these recommendations, we work as a committee to develop them. We submit them to the secretary. What are we thinking accountability looks like? What are we asking of the secretary once they get the recommendations? Is it, are we saying we just want to get an update at every one of our meetings or every other meeting on the status of how the work is moving forward? Is there something more specific we're looking for? Or do we even know what we're looking for? I do think we should have this conversation so that we are clear what we're asking, but also we can pass it on to the secretary for his information. Anyone thought about this? Should I assume we haven't thought about this? Yes, Jacob.
I think for me, it ties into a broader conversation as well of when I've talked to other groups, part of the question I get is, well, what can we do? What are you specifically asking? How can we directly help? And so I think that's something that I think it ties into something you're going to bring up a little later, but how are we translating this into actionable, very concrete, actionable things we're asking people to do? And to me, that comes back even with this accountability piece of, are there specific things we're wanting to see come out of the secretary's office, and can we be a little more concrete with very specific actions that could be taken that we think would help translate those items? I don't know what those are offhand, but to me, it sort of ties into that discussion.
No, that's an excellent point. Thank you, Jacob. Yeah, are our recommendations specific enough, or how are you taking the recommendations and moving them into actionable steps? And then what are you doing with those actionable steps? Yes, Marie.
Yeah, to that point, I know we talked about at the end of the December meeting, what departments or that are already working on some aspect of the recommendations that we have, and can we get point people to either give us updates? Yes, but what are specific concrete items as far as appropriations are concerned, as far as key influencers within each of those subsections are concerned, so that we can make sure that we are speaking to the doers and the actual deliverable entities of the work. And then the other area that we've talked about in December was what are ways that on a state level potentially people can advocate in their specific state. So what part of the recommendations can be enacted and worked upon in a state and local level versus federal level? So that's some things that I recalled.
Thank you, Marie. And that is a good point. We make the recommendations to the secretary, but many of these same recommendations, could easily be recommendations that are made to states that will ultimately probably involve implementation in the community. So how are we wording that in our recommendations? Are we asking the secretary to bless them? Are we asking them, to just elevate them more broadly throughout his sphere of influence? So I think all of that is part of that. Yes, Sherry.
And I'm curious to have a deeper understanding of what the parameters are that HRSA has to be able to implement these recommendations, what barriers or challenges that they encounter to be able to act upon them, and what influences outside of HRSA impact either positively or negatively their ability to be able to act on these recommendations.
Great point. You want to know what are the challenges to acting on the recommendations? I was trying to take notes at the same time you were talking, Sherry. So I know we're being recorded, but I want to make sure I get them as well. And I don't know if there are is there anything that, I don't know, Vanessa, anything that you all want to chime in to say as to, because, you know, we know that these are recommendations coming from an advisory committee. But once they go to the secretary, is there something more the secretary needs? We know, again, they're just recommendations from our perspective.
Yeah, I think it's a really good question. And for me, a couple things come to mind. One is there are many recommendations, and they're not actually just limited to HRSA. So many of them apply to other components of HHS, and we've got other colleagues on the call. I think one of the ones that jumps out for us often is whether there are any statutory limitations. So for example, in grant programs, sometimes folks have questions about who's eligible, or can you set aside specific funds, or can you change the way those are done? And sometimes the department has the ability to do that within the existing legislation, and sometimes not. Sometimes the legislation is so prescriptive that it spells out exactly who's eligible in what format and exactly how the funds are to be given. So that's one example where I think you always go back to what do we actually have the legislative authority to do as an executive branch agency, and then act from there. Beyond that, I think it depends on the nature of the specific recommendation, but the legislative authority is one thing that comes to mind.
This is Wendy. I just want to emphasize something that Sherry said, which was understanding. I think Sherry said it. That understanding what are the pathways that HHS and HRSA and the other agencies could be using, as well as the obstacles then to using them. So I think it's two-layer. First, what are the potential pathways? But then what are the things, you know, that we need to be specific about and work around or can't work around. I just want to make sure that it's not just finding the obstacles, but finding the paths.
Thank you, Wendy. And was Unique, were you getting ready to say something? Oh, maybe I lost her. Lost her. Okay.
Belinda, I'll just add in a quick update. The ex officios and MCHB, we did hold a meeting in early March to specifically talk with each other about how we might be already implementing or adopting some of the recommendations, or have plans to in the near future, or which ones may be stretch goals for our agency. And so we had a really great conversation amongst each other, the ex officios, and we agreed to continue meeting probably in conjunction with when the committee meets to continue to update each other on the work that's happening or planned to happen around the recommendations, but also to be able to lean on each other for support or looking for areas we could collaborate or synergize, again, to move any of these recommendations forward. And so I don't know if other ex officio members want to mention one or two things that you had shared on that March call, because I was personally very impressed with the work that was already happening related to the recommendations. And I know, Tina, not to put you on the spot, but I know you had another meeting and commitment to go to, and so your time was limited with us if we haven't already lost you. So I just wanted to see if Tina wanted the floor before she had to hop off from IHS.
I Thanks, Vanessa, and hello, everyone. I'll go ahead and just present some brief updates from IHS. Just again, I have another commitment at the top of the hour, but I'm Tina Patara-Lau. I'm the maternal child health consultant for the Indian Health Service. I'm also an OBGYN providing care to American Indian and Alaska Native patients here in Phoenix, Arizona. I'm currently on the ancestral homelands of the Ohodum Judah tribe. Thank you for the opportunity to participate and present updates from IHS today. Thank you again for being very specific in in the committee's recommendations, and certainly something we at IHS are listening to and using as we craft our path forward. So specifically looking at 3 areas that were involving the programs and policies for IHS, recommendations 15 through 17 to evaluate, fund, and improve oversight for IHS. I wanted to call to your attention that last year in December, the Consolidated Appropriations Act for fiscal year 2023 was the first time in history that IHS has received advanced appropriations to guarantee healthcare services for the agency, and that will not cease during a lapse in government appropriations and align IHS with other federal healthcare providers. So thank you to our tribal nations, tribal and urban Indian organizations, and others across Indian country who've advocated on behalf of IHS for this important support. Simultaneously, in January of this year, IHS leadership implemented the 2023 Agency Work Plan. This outlines critical priorities that will guide agency improvements over the next year and complements ongoing activities to improve patient safety and provide critical oversight of our programs. The work plan also prioritizes enhanced partnerships with tribes and urban Indian organizations, including focus on communication. So we are turning this forward into regular updates on our IHS website. We'll be launching an MCH specific website, as well as continuing our twice monthly email to the field that does share resources. With regards to recommendations to expand and diversify the workforce, and as always, the strength of IHS is really in the collaborative practice that we see, and especially in our rural settings with midwives, as well as our family medicine providers. And so our agency work plan does prioritize implementing a workforce development plan, as well as development of diversity and equity, inclusion, and accessibility programs. We'll also continue to support our mentorship program for midwifery students and expanded partnerships with academic centers, including some global health fellows, and allowing for training rotations at our IHS sites. And then lastly, the recommendation to strengthen our approach to adapt and augment social determinants of health. As you are aware, and as my patients will tell me, IHS is a unique delivery care system. Many patients do reside in maternity care deserts. Often there are barriers to accessing care in the clinic, and these include transportation, childcare, housing. And so we are mindful of that as we create our policies and programs moving forward. We are looking to work with maternity care coordinator programs to provide telehealth and home visitation support to help supplement the work we do in our clinics and hospitals, and really support the parent and child diet from preconception to through pregnancy, as well as postpartum. Hopefully, again, to increase patient access to care, as well as screening and education and intervention when possible. This will be done in partnership, of course, with our public health nurses, community health workers, doulas, and birth support workers. So, thank you for the opportunity to update today.
Thank you, Tina, and thank you for joining us today. Does anyone else want to share anything quickly? Any of our other ex officio? Don't have to be shy. We take whatever you have done so far, whatever you're planning to do. I see you, Charlene.
This is Wendy from, go ahead. For Charlene.
Oh, gosh. Thanks, Wendy. I'm sorry, I was trying to find the hand raise.
Yeah, exactly.
Thanks so much first to Michael and Vanessa for convening us as a group. It was really helpful to hear from everybody in planning for this session. I'll talk about a few things that are going on across the agency just to update folks. CDC is committed to disaggregating data by race ethnicity with recent attention to categorization for American Indian and Alaska Native populations specifically. And to date, as I mentioned, DRHS published the brief Pregnancy-Related Deaths Among American Indian or Alaska Native Persons, data for maternal mortality review committees in 36 US states. CDC has implemented methods for classification of AIAN persons with advising from tribal organizations to better capture those that identify as American Indian or Alaska Native and will continue to use this methodology in future work. CDC's Division of Reproductive Health will also continue to develop a tribally led maternal mortality review committee in partnership with tribes. CDC will expand funding this year to increase support for these activities, and once implemented, the tribally led MMRCs will receive technical support to use the Maternal Mortality Review Information Application, or MARIA, platform. CDC encourages MMRCs to identify all pregnancy-associated deaths among all populations, to determine which are pregnancy-related and report those findings as appropriate. Though some state laws and legal processes may prohibit reviews of deaths under certain circumstances, like homicide, deaths with suicide and overdose as a manner of death are regularly reviewed by MMRCs. And this year, CDC will provide funding to MMRCs for key informant interviews of surviving family and friends as appropriate and as state laws allow, as it is important to listen to the stories of these individuals. Also this year, CDC will partner with the National Institute of Child Health and Human Development to update materials for the Healthy Native Babies Project, and will focus on efforts on prevention of sleep-related deaths. The update of the Healthy Native Babies Project will engage tribes, tribal leaders, and tribal organizations in review of current materials, and will use feedback to inform development of new culturally appropriate materials for use by these populations. CDC's Division of Reproductive Health continues to support the Hear Her campaign as well. To date, we've launched the Hear Her Personal Stories of Pregnancy-Related Complications from American Indian People, and CDC will continue to amplify the voices of pregnant and postpartum persons who experience complications during or after pregnancy. And to further support engagement with AIAN populations, the Division of Population Health, which is a division located within the National Center for Chronic Disease Prevention and Health Promotion, where DRH is also located, maintains the Healthy Tribes programs to promote health, prevent disease, and strengthen cultural connections to improve health and promote wellness. This year, the Division of Population Health is launching a new funding cycle for the Good Health and Wellness in Indian Country program, while also maintaining funding for Good Practices for Wellness in Indian Country program and the Tribal Epidemiology Center's Public Health Infrastructure program. The National Center on Birth Defects and Developmental Disabilities, Surveillance for Emerging Threats to Mothers and Infants, or the CETNET, is looking at ways to engage directly with tribal epicenters to include AIAN communities in surveillance to protect mothers and infants from infectious disease threats, and to ensure that public health recommendations that are based on CETNET findings are developed specifically for these populations with a focus on cultural sensitivity. And finally, the Center for State, Tribal, Local, and Territorial Support has published a new funding cycle for strengthening public health systems and services in Indian Country, for tribes and tribal organizations to improve the quality, performance, and infrastructure of tribal health systems, including workforce, data, and information systems, and programs and services. And that's just a snapshot of what we're doing here at CDC to implement the very thoughtful recommendations made by the committee to the Secretary. Thank you.
No, thank you, Charlene. I was trying to keep up and take notes with everything you were saying, so thank you.
I'll drop them in the chat, Belinda.
Thank you so much. You were reading my mind. Wendy, are you still there? Want to chime in?
Hello, I just wanted to say that I've met, I'm from the Administration for Children and Families, and I've met with the Administration for Native Americans at ACF, and we've had a series of meetings, and we're developing basically a letter sort of to outline the various channels we're sharing the information out on, and various activities, much as Charlene has done and others have done here, and the various activities we're working on. We're a little, we weren't able to make it to the meeting, but we're working on getting that information back to the committee.
Thanks for letting us know, Wendy. We appreciate that. And I see Danielle's hand is up as well.
Yeah, I was just going to follow up. So technically, I'm also a part of CDC, although a little bit separate based on some funding structures. However, one of the things I'm trying to do is start a special report looking at AIN infants and during pregnancy, some of the birth birth items that we have with the birth certificate and with the linked birth and infant death file. And one of the things that I do remember being discussed in some of the earlier meetings is how for American Indian Alaska Natives, they in many cases don't always identify as just singularly American Indian or Alaska Native. And so including multiple race as a category is something I'm going to be trying to doing in an upcoming project.
Well, thank you so much, dear. And Michael, I see your hand is up.
Sure, just an update from MCHB. So our team regrouped after the recommendations were published. Of the 59 recommendations, we think 29 of them directly apply to the work of MCHB, and 19 of those 29 are things that either we or our grantees are currently doing, or we think they could do in the near term. So just a few examples of those. One, I mentioned in the overview this morning, the McVie, the Maternal Infant Early Childhood Home Visiting Program, was reauthorized, and that included a doubling of the tribal set aside. We've already operationalized those agreements with our partners at ACF, the Administration for Children and Families. They administer the tribal portion of McVie, and so we have already worked to transfer those funds so that program can grow. We're broadly looking across all of our funding opportunities to make sure that we are more inclusive in our language and our funding opportunities, and being very direct about who is eligible to apply, specifically when that includes tribes, tribal organizations, and urban Indian organizations. We are working to increase the utilization of consultation with tribes. So that happens at the HHS level with the secretary. HRSA also has a tribal advisory committee that we meet with regularly, and the various bureaus within HRSA can hear directly from tribes as well as share updates on programming. And then we all felt that the value of being invited onto tribal lands for the meeting in September was just so incredible. And we look forward to thinking about future advisory committee meetings in communities that can provide great input for the work that we're doing on the various advisory committees we host. Lastly, just a few things that we're planning on either expanding through existing grant programs or incorporating into future funding announcements were specific recommendations, for example, around increasing the number of tribal entities that receive Healthy Start funding, investing in training of AI/AN doulas and traditional birth workers, encouraging the inclusion of universal screening and referral for intimate partner violence, substance use disorder, depression, and anxiety, and identifying strategies to facilitate access to and engagement with maternal mental health services. So just a snapshot of the work that we're doing across our grant programs in response to these recommendations.
Excellent. Thank you so much for sharing that. If you said 19 of the 29, you're already moving forward into implementation. That is wonderful. Thank you. Anyone else want to share? I think this is part of the accountability, is definitely being able to just kind of share what is going on and how the work continues to move forward. I think the last question we want to take a moment as a committee is to talk about what else do we need to do to move these recommendations forward? I mean, it seems like all of us are going down different paths, trying to make sure that we are sharing the information, partnering with others to try to get the recommendations moved into implementation. Sounds like quite a few of them are in the implementation phase, so that is always great to hear. But what else do we need to do as a committee, or what else should we be doing? Any thoughts? If no thoughts, we'll take some time. Thank you, Marie.
Thanks, Belinda. The only other thing I could think of, if it would be of benefit, and I'm asking for those who have been in the committee for some time or have history, has there been opportunity for committee members to share particular aspects of the work within different departments. And so we have the luxury of having different departments that affect this advisory committee's work come to report to us. Is there a bidirectionality where committee members can also provide added support in reporting back the work and the importance of the work from our frame?
So you're asking other committee members, are there ways that we can do it? Or are you asking more from a HHS perspective? I just want to make sure I'm understanding correctly, Marie.
Yeah, I'm asking if there has been precedent of committee members reporting to our actual stakeholders within the government to share our particular diverse perspectives as it relates to the recommendations. Is that helpful? Has that been done? And if not, would that be an opportunity to add further accountability in the work?
I don't know. I'm gonna ask Vanessa if there's anything you can think of. I can see, like, with the meeting you all convened in, did you say March with all of the part ex officio, January?
The March meeting of
March meeting, okay.
Right. I don't think, well, Dr. Ward, I'll let you weigh in as well. What Marie is describing doesn't ring a bell to me in terms of the members themselves getting the chance to almost contribute to that response or joint accountability, I guess, of the recommendations. It has been more in the direction of, us either through the ex officios or inviting other, for example, bureaus within HRSA to come speak to the committee to show again that we are taking your recommendations. Here's how we are adopting or trying to implement them. But yeah, I think it's a great idea, Dr. Warren. I don't know if you want to add anything.
I think you're exactly right, Vanessa. Dr. Ramos, I think it's a great suggestion if I'm understanding correctly. And I think the meetings, almost like expanding what you all did earlier, where you all talked about what you're doing to disseminate the recommendations to date as folks move more into implementation, being able to share that as part of your role as committee members. I don't see there being an issue with that. I think it also really speaks to the fact that tackling issues like the ones that we bring before this committee require much more than just a government solution, that the solutions really require partnerships across all levels. And this could be a venue for discussing that.
This is Wendy from ACF. I do want to ask, we are planning to send the report out on multiple channels, to present on the report on multiple channels. And we were sort of wondering if PowerPoint presentation was available, like something that, and maybe it's even something that the committee would want to review and decide what they wanted to emphasize in the report. But I was just thinking, all of us going down all these different channels and each of us creating a PowerPoint. I just wondered if there was one out there already, or if HRSA had developed one for presenting to HHS or the like. So that was just one question I had.
Thank you, Wendy. I am not aware of one, Vanessa, of a PowerPoint that you all have developed. I think different ones of us have used different variations when we've shared it with other groups. And I'm not even sure if most of the time we're using an official PowerPoint. I think it's more of a conversation and then sharing the recommendations. But if you think that will be helpful, I don't know, Vanessa, Sarah, is that something we could work together on, but we would that could be shared back with the committee?
I was even thinking that some of the partners I would present with would then want to grab those slides and be using them right on down their channels. So it's just a thought.
No, I think it's pretty much in line with what Phyllis was asking earlier. Do we have any templates for any of the work we're trying to move forward, just to make sure we've got consistency going across the board? So thank you, Wendy, for the question. And I don't know, Vanessa, if you want to chime in now or think about it, I'll go on to Phyllis while you're thinking. Sure. Okay, Phyllis.
Yeah, one of the things is, it sounds like we are all working very hard at wide dissemination of the report and recommendations. And I keep thinking about the so what is, of course, we all expect that health is going to improve for these women and mothers and babies. But are there, as a part of the accountability, I keep thinking, what would it look like if these 59 recommendations were all widely implemented? And is there some type of metrics, with maybe not being so prescriptive, but I mean, are there indicators that we should be looking for or thinking about long-term that shows a difference? I'm working with another federal advisory group and that's doing a strategic plan, and we all had to come up with metrics, and they were pretty general kinds of things. But I'm thinking about for instance, in grants that some of Dr. Warren talked about, do we look at how many more women, Indigenous women and babies were included in programs or demonstration grants where it's appropriate, or just what should we be looking at that that so what that we really made a difference?
That's a really good point, Phyllis. Is there something, if I'm hearing you correctly, is there something we're tracking to show the movement of the work? Is there some metric or something of that nature? And I think, I think Dr. Warren gave a really good example when he went in and started sharing that 29 of the 50 recommendations kind of sat in his shop. And then of those 19 of the 29, they're actually moving forward. So having more of those kinds of things that actually have a way to clearly see what is actually moving forward with the work, I think that is important. I don't know if you have other thoughts about how to move it forward or a certain recommendation around that, Phyllis. I am taking notes on what you just said, though.
Well, again, and not to put Dr. Warren on the spot, but in his report, he talked about increased funding across several programs. And I think I heard something about increased funding for home visits for Indigenous women, those populations. So I think that then says, yeah, somebody was listening to the recommendations. Right. So not to be, I don't think it should be onerous or that kind of thing, but are there things that we should be looking at or thinking about as we or maybe as people report back on what's happened, in their state kind of thing, or whatever, or agencies, or that kind of thing. But just something to think about, I think.
Thank you, Phyllis. Jacob?
This might be a classic case of misremembering, but one thing I wanted to check in, because, when Marie was saying, what can we do? I'm sorry to paraphrase you, Marie, but like where we can be more active, right, as committee members going out and spreading this more broadly. Something tickled in the back of my brain, though, about that we as committee members are not to speak on behalf of the committee. Am I misremembering that in some way? I felt like there was something that we'd been, that the chair of the committee spoke for the committee. And so I just want to be sure, what framework we can operate in. I'm a state employee. There are things I can and can't do as a state employee. So I'm curious what our role can be in being more active in that way, or if there are restrictions and parameters that we need to think about.
No, that is an excellent point, and I don't know if I can answer that question. I think the conversations we've had in the past have been more in line with it's one thing if you're moving, if you're sharing, these are the recommendations as a committee we all came up with together, and we view them as important because we have moved them on to the secretary. I think anyone on the committee could say that if there's anything there that would be construed as controversial or anything. And like you, Jacob, I'm also a state employee, so I'm always cautious of which direction I'm going. But, if you stand behind the fact that, these are the recommendations, we move forward. I think we're all fine. So if there's something you get nervous about and you're not comfortable sharing, then maybe let's have a conversation about it. But I don't know if there's any special guidance, Vanessa or Michael, that came to us that I'm not remembering right now.
I'm not thinking of anything in particular, but we can look into it. And Dr. Ren, I saw you go off mute as well. I don't know if you were going to say something, but I will make a note to see if there's anything we might have missed.
Yeah, the only couple of things that come to mind for me is one, if there are media inquiries, we typically ask folks to come back and work with staff and the chair if there are media inquiries related to the work of the committee. And then the other is just always being mindful of conflicts of interest and any of those that may come up and the work you're doing. But we can certainly work with Vanessa and Belinda and both in packaging some of this into like a slide deck that folks could share or use to present. We can work with the team on that.
Thank you, Jacob. Does that get to what you were needing?
It does. Thank you so much.
Wonderful. Thanks. Okay, as we wrap up this session, I don't want to cut anyone off. Thank you all so very much, and especially thanks to our ex officio members for the work that you were able to share with us today, that you're moving the recommendations forward. So we greatly appreciate that. Now we're going to go into a very short discussion around framing. And I don't know, I think one of the things when I think of framing is, it's always what we say and how we say it is so important. As we need to, make sure we're having engagement at all levels in this work. I don't know about you all, but in my, community and in my state, and I'm hearing from others, from other states and others communities around some of the how things are being framed and how things are not moving forward in a way that they thought they would move forward, because some of these things have become controversial for whatever reason. And we all know on this committee the importance of maternal and infant health and making sure that we are moving that work forward. But we also know that how we say it is important, because we need engagement at all levels. We know this work is important. And I don't know if you all have been hearing things in your communities, or if you just turn on the TV and you're just like, oh my goodness, I can't believe this is an issue that someone would not support. But one of the things that we have spent time really thinking through in some other areas that I work in has been around how we are framing our conversations, how we are framing our discussions, how we're framing them in a way that we can get engagement and some level of buy-in from as many individuals and entities as possible. And so I don't know how many of you all are familiar with like the Frameworks Institute, or any of you have worked with them. We have worked with them in our state in a couple of areas. I think probably the area where we've spent the most time working with them in our state has been around the issue of tobacco use and how we frame the whole conversation around, utilizing tobacco products and things of that nature, especially when we're in a state for years and years have been known to be a high tobacco producing state. So I know we have pulled in frameworks and other types of entities of that nature, and wanted to talk a little bit today around any examples that you all are hearing in your own communities around the language, around how equity is being perceived, and how we can kind of get ahead of this as we're thinking through our next level of work and what we're doing first, and how we're wanting to really elevate maternal and infant health in a way that no one should be against it, that is such an important part of everything that we're doing. In your briefing book, you should have received some information around, I think it's in I can't remember what page in the briefing book, but some information around there's some very short video clips that Frameworks does, where I think they have like 7 or 8 short video clips. They're like 5 minutes each. That really talks about how do you frame your message in a way that is reaching the population you're trying to get it to reach. And so they've done a really good job of pulling these together. And I wanted to see if this is something that you all would be interested in, maybe us trying to get a Frameworks or some type of entity like Frameworks to come and talk to us around our messaging approach as we move forward some of this work around maternal and infant health. So I guess my first question to you all is, are you hearing these messages in your communities? And are you struggling with it, especially as you're looking at issues of maternal and infant health, and especially as you roll it into health inequities? And if so, how are you dealing with them in your own communities or in your own state?
Belinda, I guess one thing I would just share is hearing pushback about maternal mortality, in particular, like skepticism from the OB community that the numbers are really real. And by that being like, oh, well, the definitions have changed. It goes out to a year. It includes overdose. It includes a lot of things that have nothing, quote unquote, to do with obstetric care, because it's really hard for OB providers, it seems, to move past that understanding of like scope and pregnancy relatedness not being like an indictment of their practice and care. And even I'm on ACOG's Regional Maternal Mortality Review Committee, and the whole conversation seemed to shift to like preventability seeming as a threat to like providers, and that, you know, not around the scope where preventability is presented through the CDC, which is truly like communities being safer and healthier, you know, lives from the very beginning. They're looking at it as like, I hear preventability is like the doctor didn't do something right. And so there's this like general skepticism and like defensiveness among, I've seen OB practices where they, rather than saying like, yes, we're broadening our understanding of maternal mortality, we are taking accountability for the lives of the people we care for through that 12 months. We want to see moms get through, and we're not going to be like, not it just because it's an overdose or a car accident. We're going to like try to take accountability for it in order to make, you know, that entire period safer. So I do see that happening a lot around, rather than sort of embracing the recommendations, it's this just general pushback around what preventability means and what those rising numbers truly mean. And so I do think there's some understanding of like those definitions are not tied to how they used to be, which is truly like pregnancy related being like what happened related to care alone, that it is really an all-encompassing perspective around society, care for pregnant and postpartum people. I don't have a great answer for it apart from like addressing it one at a time, but it does become, it's definitely something, particularly among like, I would say, OBs not very involved with like academics or public health, like they're, you know, just in practice when they see the numbers and they hear the stats, you know, it gets back to like a not it type of feeling. So I do think there may be just general education or outreach to organizations like ACOG, like rank and file OBGYNs, like to not to better understand that this newer perspective on maternal mortality.
That's a really good example, Charlene, and thank you for sharing it. Because in reality, you know, as we've got these maternal mortality review committees and people are out, you know, reviewing the deaths and making recommendations, if people aren't open to the recommendations, how does it change the processes that, you know, we put in place? So that's a really good example, and I appreciate you sharing it. Marie, I see your hand is up as well.
Yeah, the work that that the Academy of Family Physicians is working on currently speaks just to that, Charlene, that this fourth trimester, we say it loosely, but it's really that year postpartum, and recognizing that part of maternal infant morbidity and mortality, it is the continuum from being pregnant and then turning back into, you know, chronic conditions that can yield into worsening health outcomes as well. And so how to, you know, how do we share the importance of understanding postpartum care and the issues related to maternal mortality and morbidity to healthcare clinicians that just see adults? Because oftentimes, if there's anything related to female organs, it is reverted back to the OBGYN community, and it's not considered a part of just continuity of care and preventive care in general for those who have uteri. So I think that is part of the messaging, that this is primary care, that this is essential for public health, which means that it needs to be foundational information and the front of mind when anyone with a uterus comes to the office. So I appreciate your words, Charlene, and hopefully that adds some context as well.
Thank you, Marie. Jacob, I see your hand.
We talked about this a little before, and I just sort of want to bring it back in the context of what you're discussing, Belinda, is that, our states are in very different places in this conversation, just across the whole country. And, just as an example, we be very careful with my wording here, but, our most recent legislative session in Wyoming, we finally expanded postpartum Medicaid for 12 months, and it passed 16-14. It was one vote. So we still have a lot of baseline education that we have to do to accompany some of the recommendations sometimes. That I think that packaging is important to be kind of strategic and targeted to where our target audience is in the process. Because of course we all agree with the need of health equity, but some people aren't even at that point of the conversation if we're passing by one vote, postpartum Medicaid expansion. So I think thinking of that's sweet. And that's what I like about what you're saying with framework. If we can make that flexible and adaptive to where an individual state is, I think that's how we could help move the needle in some places too.
Thank you, Jacob. And again, another great example there. And congratulations for extending Medicaid for 12 months in the postpartum period. We're just at our 1-year anniversary in North Carolina, so we understand. Thank you. Phyllis?
Yeah, and I think it would be helpful too that we get people to think about it's a childbearing year. And while we are focused on the pregnancy and the postpartum, but there's also preconceptual care that needs to be included. And as we see assaults on abortion and contraception and that kind of thing, there needs to be probably some thought about that. And I also think framing is going to be really important because this newer data that's looking at some of the outcomes of the pandemic, it had particularly devastating impact on Black maternal health. And some of it is not new. We've known for a long time that we have, and so I think this committee probably will again think about looking at, is there something else we need to look at, or that kind of thing. So I think framing, and also if we think about too what's going on in the larger society about how we teach history for other people that are non-white that have contributed, and looking at that tie into health outcomes. I think framing how we talk about that is going to be really important.
Thank you, Phyllis. Joy, I see your hand.
I want to thank Jacob for sort of opening up the door to discussion about how policymakers fit in, because we have so much information about the good that comes when pregnant mothers and newborns through the first few years of life before they become eligible for public school services, when funding is provided for quality programs, health and education, and childcare, everyone's outcome is better. And so it's sort of like we keep talking about it over and over about what's going to help the situation, but it's the policymakers that have to make this happen. And so can we just start drafting legislation? I know that's sort of no, we can't, but how do we get beyond the secretary to the people who can draft the legislation to improve the outcomes?
Thank you, Joy. And I do think that again is part of how we frame the message. And how do we move closer to political will, which I think occurs differently in every community. I think it's one thing what may happen in Congress, but we all have our own state legislatures, we have our communities. And so I do think that's a very good point. I think this is a longer conversation that we want to have. But I do think it will be helpful if you all are in agreement, if we can try to bring in someone like a frameworks or some entity that can kind of help walk us through this piece. and help us think through it a little bit more clearly about how do we get the message out, realizing that the message will be different from each community. One community may be prepared to hear the message this way, the next may be prepared to listen to it in a different perspective. So do you all have any thoughts about that? Is it something you would want us to try to move forward? I will work with Vanessa and Sarah on that for a future meeting.
I
just
think,
let me know.
I think it just has to be bipartisan. That's my only request, that it can't be too left or right leaning, that it has to be a message that, you know, that if we really want this to move forward, we're gonna have to be really careful. So I'm a little cautious about what Frameworks is going to do. So I'd be curious to see what their plan is. Like, are they actually going to listen to us and what we're saying and like take our recommendations? So I'm cautiously optimistic.
Okay, thank you, Tara. And again, as I'm shared, I do think it's different from community to community. So I think what Frameworks does, based on my experience, is they help you craft your message for your multiple communities, because different communities are prepared to hear messages differently. So I do think that your thought is noted. So thank you. Anyone have an issue with moving forward with this? You drop it in the chat or come off of mute and say so now. Or as they say, or forever hold your peace. Don't see anyone coming off. Don't see any movement in the chat. Serena, you want to reach out to me privately? You have my email, so you can also do that also. All right, so we're closer to getting back on time, but we are down for a short break. So why don't we just shorten our break and do 10 minutes instead of 15, just so people can get up and stretch. It's cool here today as well, Jacob. Our version of cool, not your version of cool. So if we can all come back at 2:30, we'll be right back on track. So thanks, everyone. 2:30 Eastern time. 2:30 on my end on the East Coast. Hopefully you had a nice short break there. As we continue on with our agenda, our next session is on data. We're doing a refresher on infant mortality, maternal mortality, severe maternal morbidity, as well as pregnancy-related mortality. And so we are very fortunate to have with us an awesome data team to share with us today, and we're going to pass it on to them. So first we have Danielle Ely will start, then Donna Hoyert, Ashley Basaka, and Ashley Haraya. And anyone's name that I mispronounce, please forgive me right from the beginning and pronounce it correctly, so I will learn better for the next go round. So we'll start with Danielle.
Thank you, Belinda. So my name is Danielle Ely, and I'm from the Division of Vital Statistics in the Reproductive Statistics branch. And today I'm going to be discussing what data we have, and then some basic statistics on infant mortality by a variety of maternal and infant characteristics. Next. So currently the 2021 final data for births, fetal deaths, and infant mortality from the general mortality file is available. We also have provisional estimates through Q3 of 2022 for births and for infant mortality from the general mortality file. We're expecting to release a provisional birth report with the 2022 data in May, and the final data should come out in August like it has in the past couple of years. Additionally, we expect to release a provisional fetal death report with 2022 data in the fall, and the final fetal death data to be released by the end of this year. Next. The linked birth and infant death data, which is the file that I manage and where most of the information for this presentation comes from, is available through the 2020 period and 2019 cohort data. We're hoping to release the 2021 period and 2020 cohort data by the end of May. However, we have run into some delays this year. We're also developing a provisional linked file report, and we hope to release it for the first time later this year with the 2022 provisional data. Next. So the linked file matches infant deaths with their corresponding birth certificates. which allows for a more in-depth analysis of factors related to infant death. And this can include things such as the maternal demographic characteristics or pregnancy risk factors. Next. In general, the maternal race and ethnicity data from the linked file is considered more accurate than the race information from the general mortality file because the mother is self-reporting this information. In general, regarding the linked file, we've been trying to work on more timely releases of the data. And one way that we have done this for data users is to release a single file that can be used for period or cohort analysis. Rather than having two separate files, we have to look over and then release. And this began with the 2017 period and 2016 cohort data. Next. Over time, the overall improvements in the timeliness of the linked file data are related to the improvements in the timeliness of the mortality file. We're continuing to try to release the final linked files earlier. There have been some limitations to this, and some of this is related to IT resources. Additionally, one of the things we're hoping to do is release this provisional data in a report, which should get some of the linked file infant mortality information out about 6 months earlier than the final data comes out currently. Next. So this is the last little bit before I actually show some data, and that's on the fetal death data that we have in our branch. We recently released the 2021 fetal death file, which includes both demographic and cause of death information. We're now able to release demographic and cause of death at the same time because of improvements in overall in the cause of death coding. So national cause of fetal death wasn't available until 2014, the 2014 data year that is. And we released demographic and cause of fetal death at the same time for the first time starting in 2017. Next. So this figure is showing the total early fetal and late fetal mortality rates from 2000 to 2021. Over this time, total fetal mortality declined 13% to 5.73 deaths per 1,000 live births and fetal deaths. And the early fetal mortality rates declined 11%, and late fetal mortality rates went down 16%. However, even looking at these and these declines have been relatively small over time. Next. This figure is showing the declines in perinatal, total infant, neonatal, and post-neonatal mortality rates from 2000 to 2020. The total infant mortality rate declined 21%, the perinatal rate declined 19%, neonatal declined 23%, and the post-neonatal rate went down 18% over these 2 decades. Next. Here you can see the infant, neonatal, postnatal, and perinatal mortality rates for just the most recent years. So from 2015 to 2020, the perinatal rate declined 6% to 5.64. The overall infant mortality rate declined 8% to 5.42. The neonatal rate declined 10%, and the post-neonatal rate went down 5%. Next. This figure this figure came from a perinatal report and showed declines for non-Hispanic Black, non-Hispanic White, and Hispanic women from 2017 to 2019. For each of these groups, rates declined between 4 and 5% over that time frame. Next. One of the things that many of you probably know is that infant mortality does vary by maternal age. Infants of the youngest mothers, which are those that are under 20 years of age, have the highest mortality rates, and infants of women in their early 30s have the lowest. Next. The 4 years of data included on this slide, 2017 to 2020, are the years that we have national reporting on single race non-Hispanic race data. So during this time period, rates declined 5 to 8% for infants of Black, Native Hawaiian, or other Pacific Islander, Hispanic, and white women. Infants of American Indian or Alaska Native women and infants of Asian women had even larger declines over this time period, which were closer to 17%. Next. The next couple of slides are focused on gestational age data. So in 2020, 10% of infants were born at less than 37 weeks gestation, and this varies by maternal race and Hispanic origin. The percent preterm was lowest for Asian women at 8.5% and highest at 14.4% for Black women. Next. Infants born preterm have substantially higher mortality rates than infants born at term. And those born at the lowest gestational ages have the highest infant mortality rates. In fact, if we break this down even further than what is here, you would see that even higher rates for those at 28 weeks or less gestation. Next. Similar to the percent born preterm infant mortality rates vary by maternal race and Hispanic origin. And infants of Asian women had the lowest mortality rates, which were about half of the rates that we see for infants of Black women who had the highest rates. Next. The next few slides are showing infant mortality by a few select maternal characteristics that I thought might be of interest to this group. Infant mortality by WIC receipt varied by race and Hispanic origin. So infants of white women who received WIC had higher mortality rates than infants of white women who did not receive WIC. This is different from the infants of Black and Hispanic women. So infants of Black and Hispanic women who received WIC had lower mortality rates than infants of Black and Hispanic women who did not receive WIC. Although there were differences in WIC receipt for American Indian and Alaska Native or infants of Asian women, these differences were not statistically significant. Next. So when looking at infant mortality by source of payment, infants of all maternal race and Hispanic origin groups had similar patterns. Specifically, infants who used Medicaid had higher mortality rates than infants born to women who had private health insurance. Although you can see there's great variation across the groups in terms of the actual infant mortality rates. Next. When looking at infant mortality by source of payment, infants of all maternal race and Hispanic origin groups had similar patterns. Infants born to women who used Medicaid had higher mortality rates than infants born to women who had private health insurance. Next. Oh, you know what? I just completely, sorry, I skipped over something. By timing of prenatal care, infants of women who received late or no care, and that is the prenatal care in the third trimester or receiving no care, had higher mortality rates than infants of women who received care in the first trimester of pregnancy. So the rates for infants who were born to women who received late or no care were between 66 and 187% higher than those who received care in the first trimester. Next. So I'm going to quickly go through some of the leading causes of death. In the next couple slides, look at this. This slide looks at the 5 leading causes of total infant death, both in 2015 and 2020. So in both of these years, they had the same 5 leading causes of death, which included congenital malformations, low birth weight, maternal complications, SIDS, and unintentional injuries. So compared with 2015, the rates declined for 4 of the 5 leading causes, but there was a slight increase for unintentional injuries in 2020 compared to 2015. Next. Here were the 5 leading causes of neonatal death in 2020. These included low birth weight, congenital malformations, maternal complications, PCM complications, and bacterial sepsis. Next. These are the 5 leading causes of post-neonatal death in 2020, which included SIDS, congenital malformations, unintentional injuries, diseases of the circulatory system, and homicide. So the leading causes of death for overall infant and by age of death have generally been the same for at least the last decade of data that we have available. Next. These next few slides focus on geography. So in 2020, infant mortality rates ranged from 3.92 in California to 8.12 in Mississippi. And as you can see in the map, the rates were generally lower in states in the West and the Northeast and higher in the states in the South. Next. So while the infant mortality rate has declined over time, and throughout the United States. From 2015 to 2020, 13 states and the District of Columbia had declines in rates that were statistically significant. In this map, those states are filled in with blue to make them easily seen. Next. So infant mortality rates also vary by urbanization level. From 2015 to 2020, the infant mortality rate declined for all urbanization levels, but non-metro counties had the highest infant mortality rates in both time periods. In 2015, rates in non-metro counties were 6% higher than the rates in smaller medium metro counties and 25% higher than the rates in large metro counties. And in 2020, the non-metro rates were 4% higher than smaller medium metro counties and 27% higher than those in large metro counties. Next. This was a quick stat publication that looked at infant mortality by maternal race and Hispanic origin using a metro non-metro dichotomy. So infant mortality rates were higher in non-metro counties for all groups. However, they were only statistically significantly higher in non-metro counties for infants of white, Hispanic, and American Indian or Alaska Native women. Next. So to kind of wrap up and conclude, over the last couple decades, fetal, infant, and perinatal mortality rates have declined. There have been declines in rates by maternal race and Hispanic origin. Next. Mortality rates continue to be highest for infants of Black, American Indian or Alaska Native, and Native Hawaiian or other Pacific Islander women. And infants of Black women have mortality rates that are nearly twice as high or more than those for infants of white, Hispanic, or Asian women. Next. Black, American Indian or Alaska Native, and Native Hawaiian or other Pacific Islander women had the highest percentages of preterm births, and their infants have the highest mortality rates among those born preterm. Next. Infants of Black and Hispanic women who received WIC had lower mortality rates than infants of Black and Hispanic women who did not receive WIC. But the opposite was true for the infants of white women. Infants of women who received Medicaid had also had higher mortality rates than those of women with private health insurance, which was the case across all maternal race and Hispanic origin groups. Next. Infants of women who received late or no prenatal care had higher mortality rates than those of women receiving care in the first trimester, which was also true across all race and Hispanic origin groups. Next. Here's just a quick review of the 5 leading causes of infant mortality and by age of death. And something to note that is, I did not necessarily talk about completely earlier, was that the same 5 leading causes of infant mortality have been the 5 leading causes since 2006, with some minor changes in order. For neonatal mortality, these have generally been the same 5 leading causes since 2007. However, in 1 year, bacterial sepsis did fall off, but it did come right back on the next year. And for post-neonatal mortality, they have had the same 5 leading causes since 2010. Next. From 2015 to 2020, 13 states and DC had declines in infant mortality. So overall, infant mortality rates are higher in non-metro counties than in metro counties. And this is generally true by maternal race and Hispanic origin. Next. And kind of looking ahead a little bit, we're going to continue to work on the timeliness of the period and cohort final data, and not just in terms of the file releases, but also by trying to publish on provisional data. And that is all I have for today. Thank you.
Thank you, Danielle. We're just going to hold all questions to the end and move on to Donna.
Yes, I can start with what's going to be on the title slide. So I'm in the same division as Danielle. I'm going to talk about maternal mortality data from the National Vital Statistics System. Next slide. The National Vital Statistics System maternal mortality data from NCHS comes from death certificates and the cause of death statements, which are completed by physicians. or medical examiners principally. The quality of the information depends on the persons completing the death certificates. NCHS uses the World Health Organization International Classification of Diseases, or ICD, and the definition of maternal mortality in that, which focuses on deaths occurring while pregnant or within 42 days of the end of the pregnancy. The measures we typically present in publications are numbers of maternal deaths and maternal mortality rates, which are calculated as the number of maternal deaths per 100,000 live births. Next slide. NCHS statistics on maternal mortality go back to the early 1900s with periodic points of disjuncture whenever a new revision of the ICD was adopted. However, 2003 marked the beginning of an unanticipated, protracted period of disjuncture, and for a reason other than a change in ICD revision. Research that had access to additional information would identify more maternal or pregnancy-related deaths than found in the vital statistics data. It was suggested that adding a separate checkbox asking about recent pregnancies would be a way to increase the numbers identified using death certificates. A national consensus process agreed and recommended adding such an item. So the expectation was that states would make this addition in a relatively short time frame around 2003. Numbers of maternal deaths identified would increase substantially. Our data would be more similar to other maternal mortality data sources, and we could move on from there. However, it took a long time for all states to add this checkbox to help identify maternal deaths. And during this 15-year period, it was found that the checkbox was being marked more often than appropriate, especially as the decedent age increased. In 2018, NCHS restarted publishing maternal mortality data after all states had added a supplemental checkbox to help identify maternal deaths. Some modifications were made to mitigate the impact of likely reporting errors with the checkbox at the same time. But as you'll note, I use the word mitigate. And the states differ in the practices that they follow to work on data quality. For our part, we have tended to send long lists of potential problems back to the states for review, but that hasn't been terribly productive. In the past year, we revisited current data with respect to data quality, confirmed some of the choices we made in the mitigation strategy based on earlier look at data quality, and are shifting to a more targeted list to ask states to focus on. The idea being that they will have a smaller number of records to follow up on, and we're more confident that these particular records really need to be corrected. And last year, we also created a separate reporting guidance document that specifically focused on these types of events. And additionally, it took some time to integrate these changes into our systems. So 2021 data is the first year that the maternal records are getting fully processed as the year goes along. Next. Since 2018, maternal data have been available in annual Health eStat, a table in the annual deaths data for X year report, and data files. A number of the following slides are based on information released last week in a Health eStat report for 2021 data. Next. The Health eStat shows that there are a number of disparities in maternal mortality in the US. Maternal mortality rates increase as age increases. In the NCHS data, the rate for women 40 and over was nearly 7 times that for women under 25. Next. Maternal mortality varies by race and Hispanic origin. In 2021, the rate for non-Hispanic Black women is 2.6 times the rate for non-Hispanic white women. The rate for non-Hispanic white and Hispanic women are roughly the same. The Health eStat only focuses on these three groups. In some of our other reports and releases, we show more groups, although the size of the groups is a common issue. Even combining years, we need one more year than we have to get large enough numbers to calculate reliable rates for the Native Hawaiian or other Pacific Island group. These smaller groups cover the range with lower rates for Asian women and higher rates for American Indian or Alaska Native women. Next. Maternal mortality differs by urbanization level, with the rates decreasing as one moves left to right on the slide from rural towards large metropolitan counties. Next. In 2021, maternal mortality was similar for women with and without a GED or high school diploma, lower for those with some college but no degree, and lower yet for those with a degree. Next. So in the short time since we restarted publishing maternal mortality statistics, the trend is increasing, with the largest increase between 2020 and 2021. We also have provisional data as we are building towards the final data. Provisional data are not complete, final, and are subject to change. In the case of maternal mortality, there isn't anything unusual about the flow into the file, but the coding is reviewed multiple times and numbers might change during these extra reviews. So provisional data have been available in the Wonder tool for roughly a year now. And that reflects the numbers as they build up and change during the course of the year. Next. Last Thursday, we also released a new data visualization that presents numbers of provisional maternal deaths through October of 2022. This visualization shows a series of counts for 12-month periods. The visualization is presented overall and by age, race, and Hispanic origin. I'm just going to show the overall figure. So in this, the December date will correspond to the time period shown in the Health eStats publications using final data. And this reflects that the increases that we have been showing in the recent Health eStats, and that the 2021 calendar year pretty much captured the height of the increase in maternal mortality. But then we see a decreasing pattern in 2022 in vital statistics data. Next. So NCHS's maternal mortality data soared during the pandemic, but 2022 looks to be returning to the levels we were calculating pre-pandemic. With respect to COVID-19 being reported as a cause, I'm next looking at mentions in the multiple cause data. For 2020, about 100 maternal deaths reported COVID-19. For deaths overall, comparing 2021 to 2020, COVID-19 deaths increased and shifted to younger age groups where there are more likely to be women who are pregnant or recently pregnant. And both the number and percentage of maternal death records mentioning COVID-19 were substantially greater in 2021 than in 2020. And then if we look forward to the provisional data, that indicates that it will be less again in 2022, again reflecting shifts in numbers observed more broadly with COVID-19 deaths. Some of the longstanding disparities, such as age and race, were just ever so slightly worse in 2020, but more like before in 2021. Next. So in conclusion, NCHS resumed releasing maternal mortality statistics with 2018 data and has expanded data access with a health eStat, provisional data, and a maternal data visualization. Long observed differentials such as by age or between race and Hispanic origin groups persist. Our current trend is not very long, but shows that maternal mortality rates increased substantially during the pandemic, and provisional data suggests that the rates will return to pre-pandemic levels in 2022. Thank you.
Thank you so much, Donna. And now we'll go on to Ashley.
Hi, good afternoon. I'm Ashley Busacker. I'm the senior epidemiologist on the maternal mortality prevention team within CDC's Division of Reproductive Health. I think my slides are coming. Okay, perfect. So today I'm going to share with you data from our recent report, Pregnancy-Related Deaths, Maternal Mortality Review Committees in 36 US states from 2017 through 2019. Next. And then next too. So to begin, I want to provide some background on the Enhancing Reviews and Surveillance to Eliminate Maternal Mortality, or ACIMM initiative, and our national reporting. Maternal Mortality Review Committees, or MMRCs, are multidisciplinary committees comprised of diverse clinical and non-clinical expertise. MMRCs use a standardized process from data collection through committee deliberations and record the information in a standardized data system, which we call MARIA. So CDC analyses and reports of MARIA data will focus on pregnancy-related deaths. These deaths occur during pregnancy or within 1 year of the end of pregnancy and are from any cause related to or aggravated by the pregnancy. This focus is because this is a population with unique causes of death. Pregnancy-associated but not related deaths tell us that an individual died during or within 1 year of pregnancy, but the death was not causally related to the pregnancy. While pregnancy-associated but not related deaths mirror causes of death among women of reproductive age, you cannot interpret the findings from these deaths to be representative of deaths among individuals of reproductive age, because they are a small proportion of those deaths that occurred among a specific population. Every death is a tragedy, and CDC's focus on preventing pregnancy-related deaths is because this is the unique prevention space that maternal mortality review committees fill. Next. So before we look at the data, I do want to take a moment to acknowledge that there are lives lost behind these data. Each number represents a tragic loss to a family and a community. Next. So in this presentation, we'll see data from 1,018 pregnancy-related deaths occurring from 2017 through 2019 to residents of 36 states, which are shown here on this map. Not all maternal mortality review committees submitted data for all 3 years, and partial years of data were received. I also want to acknowledge that we'll be showing you proportions and not category-specific pregnancy-related mortality ratios. We are not able to calculate the pregnancy-related mortality ratios using these data, but these would be the more appropriate measure for understanding disparities. Next. So this slide shows the breakdown of race and ethnicity among the pregnancy-related deaths. While you're taking in the numbers, I do want to walk through how these categories come about. Race and ethnicity data are from the birth or fetal death records when available, and from death records when a birth record or a fetal death record was unavailable. All deaths with the notation of Hispanic origin are classified as Hispanic. For non-Hispanic persons, race was classified as non-Hispanic single race American Indian or Alaska Native, non-Hispanic single race Asian, non-Hispanic single race Black, non-Hispanic single race Native Hawaiian or other Pacific Islander, and non-Hispanic single race white. Deaths which were missing race ethnicity include those with missing notation of Hispanic origin, those with a notation of non-Hispanic origin but missing information on race, and those missing notation for both race and ethnicity. Next slide. This graph shows the distribution of pregnancy-related deaths by age. Over 70% of pregnancy-related deaths occurred among persons ages 25 to 39. Next. Here we see the distribution of pregnancy-related deaths by educational attainment. Over half of decedents had an education level of high school graduate or less. And the next slide looks at timing of deaths in relation to pregnancy. Over 50% of pregnancy-related deaths occurred 1 week to 1 year after the end of pregnancy, which is a time when most individuals would have left the hospitals. Next slide. So now moving into underlying cause of pregnancy-related death. This refers to the disease or injury that initiated the chain of events leading to the death, or the circumstances of the accident or violence which produced the fatal injury. The Maternal Mortality Review Committee uses the information from the death record along with information from medical records, social service records, autopsies, and in some cases, key informant interviews to determine the underlying cause of death. The MMRC uses all the information available to code the underlying cause of death using the system shown on this slide. Next. The 10 most frequent underlying causes of death among the pregnancy-related deaths are shown on this slide. The most frequent cause was mental health conditions, which include deaths to suicide and overdose or poisoning related to substance use disorder. That was followed by hemorrhage and then cardiac and coronary conditions. Next slide. To identify opportunities for prevention among disproportionately impacted populations, it is important to look at the underlying causes of death by race and ethnicity. Among non-Hispanic Black persons, cardiac and coronary conditions and cardiomyopathy are the two most frequent underlying causes of death. When combined, these causes that involve the heart represent almost 1/3 of pregnancy-related deaths among non-Hispanic Black persons. Next. Among Hispanic persons, the most frequent underlying cause of pregnancy-related death was mental health conditions. And the next slide. Among non-Hispanic Asian persons, hemorrhage was the most frequent underlying cause of pregnancy-related death. Next. And among non-Hispanic white persons, mental health conditions were the most frequent underlying cause of pregnancy-related death. Next. A preventability determination was made by the Maternal Mortality Review Committees for 98% of the pregnancy-related deaths. A preventable death is defined as a death with at least some chance of the death being averted by one or more reasonable changes to the patient, community, provider, facility, and/or systems factors. Among those pregnancy-related deaths with this determination, 84% were determined to be preventable. The next slide. So for the next few slides, we'll focus on pregnancy-related deaths to American Indian or Alaska Native persons using the same data. Next. As I mentioned, understanding differences in the underlying causes of pregnancy-related death by race and ethnicity is important for identifying prevention opportunities to reduce pregnancy-related deaths. Accurate classification of race and ethnicity can be challenging. Methodological decisions about racial classification can affect the size and the characteristics of the population used in the analyses. This slide describes an alternative approach our team took for classifying pregnancy-related deaths among all American Indian and Alaska Native individuals. This approach is consistent with assessments from other groups, which have demonstrated the importance of examining deaths among all American Indian or Alaska Native persons, regardless of notation of Hispanic origin or other or multiple races. So as you can see, there were 9 pregnancy-related deaths classified as non-Hispanic, single race, American Indian or Alaska Native. And then there was 1 death with a notation of Native American written in the specify other free text field. 5 American Indian, Alaska Native deaths with a notation of Hispanic ethnicity or missing ethnicity, and 2 American Indian, Alaska Native deaths with a notation of more than 1 race. So with this alternate approach, we did see an increased identification of pregnancy-related deaths to the 17 number you see, but because of known limitations with vital records for identifying American Indian and Alaska Native persons, 17 is still likely an undercount of pregnancy-related deaths among American Indian and Alaska Native persons. The next two slides will describe these 17 pregnancy-related deaths. Next. 16 of the 17 pregnancy-related deaths among American Indian or Alaska Native persons had a known underlying cause of death. Among these deaths, mental health conditions were the most frequent underlying cause of death. And on the next slide, we see an MMRC preventability determination was made available or was available for 15 of the 17 pregnancy-related deaths. And among those, 93% of these deaths were determined to be preventable. Next. So in summary, pregnancy-related deaths occurred during pregnancy, delivery, and up to 1 year after the end of pregnancy. The leading cause of pregnancy-related death varied by race and ethnicity. Over 80% of pregnancy-related deaths were determined to be preventable, and methodological decisions about racial classification can impact the size and characteristics of the population used in an analysis. Next. So I wanted to thank everyone throughout the country, maybe some of you on this call, who take the time to review maternal deaths, put together the reports, and drive implementation of the prevention activities. And next slide. Then email if you have questions or want some more information. Thank you.
Thank you so much, Ashley. I did drop you a note in the chat. So now we're going to go to Ashley Harai as we wrap up this session and get ready for questions.
Thanks, Belinda. I'm Ashley Harai. I'm a senior scientist in MCHB's Office of Epidemiology and Research. Next slide. Oh, okay, I think I can control mine. So many of you are probably familiar with this pyramid showing maternal mortality and morbidity. Maternal and pregnancy-related deaths that were just discussed are really the tip of the iceberg. For every maternal death, it's estimated that there are 50 to 100 cases of severe maternal morbidity and thousands of complications, such as pre-pregnancy and gestational conditions like diabetes and hypertension. Just for some background on how kind of HRSA comes into the surveillance space is really for the Title V state block grant program, where we have a national outcome for severe maternal morbidity, or ACIMM. And we collaborate with the Agency for Healthcare Research and Quality, or AHRQ, as the data purveyor, and CDC as measure developer to populate national and state estimates for monitoring and surveillance. The data come from the Healthcare Cost and Utilization Project, an all-payer database of hospital discharge records from all non-federal acute care hospitals in nearly all states. So this graphic depicts the levels of our performance measure framework, and at the center are our national performance measures, which states select to improve over a 5-year needs assessment to action cycle. And these are shorter term performance measures of healthcare access, quality, and behavior, which in turn help to improve longer term outcomes of morbidity and mortality. So those within the maternal and women's health domain are well woman visit, low risk cesarean, and smoking in pregnancy, which influence our North Star measures of severe maternal morbidity and maternal mortality. States employ evidence-based or informed strategy measures to make progress on these performance measures, such as improving insurance outreach and enrollment, social media campaigns, and hospital participation in quality improvement efforts. So what I'm going to be covering today is really the definition of ACIMM that we use, trends, types, disparities, and some measurement issues. So moving to the definition that we use, is that developed by CDC researchers, unexpected outcomes of labor and delivery that result in significant short or long-term consequences to a woman's health. And how we measure that is from those hospital discharge record codes with 21 different indicators, including 16 diagnosis codes and 5 based on procedure codes. So these are just the overall indicators of 21, but there are over 400 individual codes that are used in these discharge records. Recent federal analyses do exclude cases of blood transfusion only due to poor predictive value in the absence of other SMM indicators. So 4 or more units of blood product is usually considered severe, and the number of units just aren't available in hospital discharge data. You can find the full list of codes at the links included here for HCUP, FASTAPS, Title V, and our AIMM Program Alliance for Innovation on Maternal Health. So all of the data I'm presenting here were pulled from HCUP, FASTAPS, or Title V, highlighting 3 recent ARC, CDC, or HRSA publications. I led the first 2 with colleagues from ARC looking at trends across the ICD coding transition and state level correlations, and I'll present data from those near the end. And then there's also, just to note, 2 forthcoming publications. ARC has an analysis of COVID-related SMM increases that will be coming out, and CDC has been working on a paper on SMM indicators that account for the largest share of in-hospital deaths. Okay, moving to trends. Over the last decade, we can see here that we're not moving in the right direction. There's been an increase of nearly 20 per 10,000 or 26% in the last decade, mostly since 2017. And there was really little or no difference across that coding transition. The largest single year change was in 2020 with the COVID-19 pandemic, an increase of about 8 per 10,000 or 10%. Prior analyses from both CDC and ARC showed increases mostly beginning in 2000 with substantially larger rises when including transfusion-only cases. So what's kind of behind these trends? It's unclear. It may be related to increases in chronic conditions and maternal age. However, a study in California showed that maternal characteristics and comorbidities couldn't explain the rise in that state. Artifactual increases are also possible due to improvements in recognition and coding with quality improvement initiatives, or increases in certain indicators with poor predictive value that may not be truly severe. So the latest increase in 2020 does appear to be directly related to the COVID pandemic. This table shows indicator groupings in order of incidence. So hemorrhage is the most common cause or type of SMM, followed by renal and respiratory failure and sepsis. Between 2019 and 2020, respiratory and acute renal failure had the largest increases on both an absolute and relative scale, and this is consistent with what we know of clinical impacts of COVID. Looking at race ethnicity, we can see that Black women have the highest rates of SMM, twice that of white women who have the lowest rates. Black, Hispanic, and Asian Pacific Islander populations have the largest increases from 2019 to 2020 of about 10 to 15%. This is not completely consistent with maternal mortality, as Asian Pacific Islanders did not have an increase in 2020. The race ethnicity data from HCUP and hospital discharge data may not always be self-reported, and not all states have adequate reporting. And I also want to mention that although American Indian and Alaska Native are represented here and do have elevated rates, IHS facilities don't participate in HCUP, so this isn't a complete picture of their data. Looking at expected payer, SMM is higher for Medicaid or Medicare billed delivery hospitalizations compared to those privately billed or having no charge or no insurance or other public insurance billed, such as military. Increases in 2020 were larger for this latter category, and Medicaid, Medicare insured compared to the privately billed patients. So contrary to what we saw for other perinatal indicators, including infant and maternal mortality, we see that SMM is actually higher for residents of large metropolitan counties than small, medium metro counties or non-metro counties. And the large metro residents experienced larger increases in 2020. Why is this data inconsistent? I think it does speak to some measurement problems here for SMM. And if we look at trends by hospital location and teaching status, increases in the last decade only occurred at metropolitan teaching hospitals, raising the possibility of improved diagnostic ascertainment or recognition in the billing record, perhaps through quality improvement activities, or increases in indicators with poor predictive, positive predictive value. So concerns have been noted beyond transfusion, as some indicators require greater clinical judgment and examination of signs and symptoms to truly determine severity. In a paper just published last year, you can see slide 5 that had the citation and link. We looked at correlations between state SMM rates and other perinatal indicators that may precede, coincide with, or result from SMM. So this is a bubble graph with the size of the bubbles corresponding to the size of the correlation, with statistical significance noted in a glowing edge and negative correlations in white. And we found that SMM was significantly correlated with only 2 of 7 other perinatal indicators: pregnancy, hypertension, and low risk cesarean. By contrast, there were stronger and more consistent correlations among all other perinatal indicators, including maternal mortality. And just as a side note, it's interesting to see the relatively high correlation between infant and maternal mortality at the state level. That's 0.56. So they share, we know they share common social and structural determinants, and this is consistent with the alignment and addition of maternal mortality in this committee. So why isn't SMM associated with maternal mortality geographically? Theoretically, SMM should be most strongly linked to maternal mortality as a near miss event, originally constructed using conditions associated with mortality. However, what we see is little geographic patterning, with the highest rates in certain states on both coasts. That's indicated by shades of orange and red. Unlike maternal mortality, which is highest in the Southeast, indicated by the size of the blue circles. So the overall correlation is negative and non-significant. California is one of several outliers with a high rate of SMM, but low maternal mortality. And all states with those darkest shades of red have experienced recent rapid increases in SMM. That was highlighted in our other study that was also listed on a previous slide. Again, this may be consistent with improved diagnostic ascertainment through quality improvement or increases in indicators with suboptimal predictive value. Specific concerns have been raised about disseminated intravascular coagulation and acute renal failure. So until more is known, caution really should be used when comparing SMM rates geographically, whether by state or urban rural residents. In addition to potential coding variation or indicator level issues that require more investigation, it's also important to recognize that most studies only capture SMM at delivery. A recent CDC analysis of publicly and privately insured patients in IBM market scan data showed that 15% of de novo or new onset SMM occurred in the postpartum period. And it's unclear how much may be occurring in the antepartum period, but an earlier study indicated it may be about 1/3 as common as during delivery. Also, mental health conditions and hospitalizations have not been included in SMM definitions to date. So we really have much work to do in refining and advancing measurement for SMM. CDC recently held a federal partners meeting on the topic, and we're working collaboratively across HHS to improve measurement, surveillance, and prevention. And I just wanted to give a shout out to Charlene, whose branch is really leading this work and whose slides I borrowed from here. So I want to give credit where it's due. And that does conclude my presentation, and I welcome questions along with the other panelists. Thank you.
Thank you, Ashley. And thank the amazing team and sharing this wonderful data. So we appreciate you all giving us a refresher. I know there have been a couple of questions that have been in the chat, and I think you've been answering as you go, but I want to make sure if anyone has a question, if you'll just come off. Okay, Tara, I see your hand.
Yeah, thank you. Those were great. Those were great presentations. I was scribbling a lot of notes. I think the biggest question I have after digesting it as quickly, my first question is, okay, so when we look at maternal mortality review committee data, you know, the latest report is from data from 2017 to 2019, and you said it's based on 36 states. So does the CDC obtain and report in-depth analysis from the other states? And if they don't, how can we ensure that they do so that we have the most complete data set that we possibly can to get the best picture? So that's my first question.
Thank you, Tara. So that was 36 states, and each time we've done a data call, we've increased the number of states. So that's good news. And now I think we're up to, pull this up, I have a hidden slide. The number of states participating in Maria, we have 40 funded states and jurisdictions, and I think we're up to like 45 or 46 data sharing agreements. Don't quote me on that, but I'll get that number to you. But the good news is we are increasing as time goes on with funded jurisdictions and jurisdictions who are using Maria. So not every jurisdiction who's using Maria right now is funded. Those states have data sharing agreements with us, which allow us, when we do a data call, to download and then analyze their data. So with our next data call, we just did a data call the end of 2022, we hope to have data from more states.
That's great. I mean, because I think that's one of the key pieces here. I think we can infer some trends that are important, but I think if we're really going to dig into the data, I think we need to get as much state data as we can, because we keep saying how there's differences throughout the country. Well, there's going to be differences in that data too. So we need to gather that. And I think trying to standardize the data that because I mean, you guys have all said it, right? There is discrepancy between the states. They're not all reporting the same type of data. And so I think this is something that I think this committee can help with, or with your help, obviously, because you guys are in this data, right? So we need your help. But I do think that this is big. And then just with the NVSS data, because that's just kind of like a snapshot, right, of what happened in 2021. So what's and then the maternal mortality data that you presented is from 2017 to 2019. So what's the plan to kind of now dig deeper into that data from the NVSS to get PMSS data and to really really understand? Because that NVSS data is great, but it's just a snapshot. So kind of when are we going to get a report, like we have from 2017 and 2019 to really understand the impact of COVID-19?
So a couple of things. One, I want to let you know too, with Maria, we're hoping to expand with new funding to all the states. I put the 48 states now using Maria. And then the question about when's new data coming from PMSS, we are soon to be releasing data which will include 2019. How PMSS works right now, we are still receiving data from 2020. So as we receive that data, we're able to do our medical epidemiology review and are working on increasing the speed of access, or STEAD NASIS initiative, to get data transferred to CDC quicker, and to do case identification within CDC should help improve the timeliness of that data. but it does require that medical epidemiology review as well as the states transferring data to us. So hopefully that's helpful with.
It is, yeah. And I think, and maybe we can talk offline or I can email you, but I think it'd be really great to kind of, how can we help you to with that timeliness, right? Because I think that data is so critical to us understanding what's happening. I think, like I said, it's important to see these trends, but if we really want to dig into that data, then especially if we're going to start looking at when a pandemic hits, right? What happened, so if there's any way that we can help you to get that data fast and to get it processed fast, let us know.
Okay, thank you. And one other point I did want to bring up is our team does work very extensively with the jurisdictions to offer that standardized process, to work on training, have office hours, have tools available. So we are getting standardized data from these very diverse states across the US. So, thank you for your questions.
Thank you. Great answer.
And I was just going to give an example. So Tara, like our state in North Carolina, we're one of the states that participate with the Maria data system. But, and it does help with the standardized process, and you have a maternal mortality review committee, but just realize it's not something that happens quickly, because you have to realize the steps that occur. We have legislation that requires providers and health systems to send us the records, but then when they send them to us, depending on where it is, you could get a box of paper. And then you've got to have staffing that can actually abstract the cases, go through each sheet and move it into a format where the actual committee can then review it. And then that committee is the one that, makes the determination with pregnancy related or pregnancy associated. So there's some of the variation that happens from state to state. So I think Ashley and the team there at CDC they're doing an awesome job in helping keep it as standard as possible, but you have to realize each system is different in each state as to how they move that data forward. So that's just one example, but it was an excellent question. Sherry, I see your hand is up now.
Yes, thank you very much for the powerful story that your data present. It's so important that we have data to direct us and inform us as to where we can make positive changes. My question is first assumed on includes the assumption that both of your organizations, agencies recognize that health-related social needs are also contributing factors to infant and maternal mortality, whether it's causal or associated to pregnancy in terms of maternal mortality. My question is for both of your agencies, and I'd like to open it up to HHS as well. When I ask, where is the system prepared to begin to collect health-related social needs, and where are the barriers or challenges to doing that?
Everybody going to answer at once? I see you coming off, Ashley.
Yeah, thanks, Sherry. That's a great question. So we at CDC have fairly recently introduced the community vital signs dashboard into our maternal mortality review committee processes. So this is a dashboard which pulls community context indicators, and there's a paper I can put in the chat from Dr. Michael Kramer, and these indicators are based on where the individual last lived and give some idea of these social factors. So there's a large group of them, they're split into domains, and the idea is that the maternal mortality review committee can look at these dashboards to give that community and social context to the case review. The other thing that the Maria data system has a place to collect what we call social and environmental profiles, so a place to note information that the committee or the abstractor finds for the case. This could come from the kind of a next of kin interview or an informant interview, but also noted in social records and other sources. So the maternal mortality review committee data, I think, has the potential to look at some of the social determinants of health and drivers of health that we maybe can't get to with just the vital records alone. And then we've also used those community indicators, the vital signs indicators, in an analysis of our PMSS data, again, based on the place of residence at death. So I can put those 2 papers in, but we really hope with our coming analyses that you'll see more of that data from our team.
Sherry, does that answer your question? You're good.
It does. Thank you very much. I'm also curious if there are challenges with coding to be able to capture the health-related social needs.
And if you want to drop the response in the chat while you all are thinking about it, Sherry, I'm going to go on to Jacob while they're thinking on that one. Okay. Thanks. Jacob.
Thank you. I just wanted to thank all the presenters for all this very, very helpful information. I had a quick question for Danielle. When looking at the infant mortality, you had a lot of wonderful data. I was trying to very quickly synthesize it as you were going through. Are you seeing any, even if it's not statistical, numeric trends in closing the inequity gaps? So, it's great that we have our infant mortality downturning, but is it just going down equally across all the groups who are not actually closing our disparity gaps? Or I don't know if you had any indication from your data that you could comment on.
One of the, if you're thinking back across the many, you're right, I included a lot of information because I know there are a lot of things that people are interested in. And so going quickly was the best I could do on that. If you think back in terms of inequities by maternal race and Hispanic origin on that slide that I included from 2017 to 2020, that's just using the single race, just the fact that we're seeing infant mortality rates decline at different percentages or different rates, or I hate saying rates multiple times, but comparing like some groups at the 5 to 8% level, which is a little bit more equal, but then we're seeing these larger declines of 17% for some of the other groups. Or then if you're looking at declines by place in terms of states, we see states with greater declines. Granted, some of that is because some states had further to go compared to other states over time. So in general, I think you would say that some of the disparities are closing while others might be getting larger. And some of that will depend on what groups you're looking at, what kind of information you're trying to get to. But in general, I think you can easily say that there are some improvements, but also probably some places where it's getting worse.
Thank you.
Thank you. Any other questions? I know we're running a little bit over time, but I know this data conversation is so important as it drives our work as we continue to move forward. I know there was one question I think, Phyllis, you dropped in the chat. So I don't know if you got your answer or not. It was around, I want to say injury.
Yeah, Belinda, I'm working on typing a response. So
oh, okay.
If you want to pretend I can type it or I can talk, whichever.
Yeah, thank you. Just my own interest is domestic violence and pregnancy outcomes. And we did see during the pandemic a lot more calls from women who were, forced to be at home with abusers. And I have written a paper on pregnancy associated deaths, but I was just wondering if there is any systematic tracking of that data also.
So within the Maternal Mortality Review Committee data, we do have data on pregnancy-related deaths, that then the manner of death was intentional, so suicide or homicide. We would have some recommendations there. Is that helpful, or are you looking for? Okay, so yeah, I'll put some information in the chat, and then I also see the question about the Maria state, so I'm going to drop a photo of a map.
Thank you all so much. Sarah and Emma, one of you all, can we make sure we grab the chat before the meeting is over, because we're getting really good information in the chat, especially all of the the links that are placed there so that we can get them back later to the, be really helpful.
Yes, we will.
Thank you, Emma. And if you all can join me in thanking this awesome panel, you all did an amazing job. So thank you all so very much for this great data. Got a long ways to go, but we appreciate you all sharing the data with us. And as we, now that we've had a chance to really review the data, now we're going to go into our next session on around where does the committee go from here. And again, we just spent time reviewing this data in great detail. They've answered all of our many questions, and I'm sure more questions will come, but we wanted us to take some time today to just think about what are our next steps as the ACIMM committee. Where do we want to go next? And want to have a short conversation with this committee about those things. So one question that kind of comes to mind is, first of all, is there any work that we have left kind of unfinished that we need to wrap up from the last committee? If anyone can think of anything, if you will come off of mute and share that, we by all means will continue to keep our options for American Indian, Alaska Native, as we want to make sure that work continues to move forward. And we prioritize that. So we will definitely continue that. But did we leave anything that we might want to touch bases? And Vanessa, we hope you feel much better soon. Thank you for dropping that in the chat. And if we haven't left anything off that we need to wrap up, I want us to now talk about where do we want to focus on next? So as it was shared earlier, I know everyone came on at different points in time into this committee. So this last go round, we actually had 3 sets of recommendations that we moved forward to the secretary. But at this point in time, now that we've looked at the data, we've had some conversation around framing, and we're going to try to bring in someone to share a little bit more information and guide us through the framing process. I really want us to think through what areas do we want to focus on next to improve maternal and infant health in this country. We definitely want to make sure that the voices of individuals with lived experience are elevated, and we'll get to hear more of that tomorrow when Sharonda is prepared to share her story with us. And we want to continue to make sure we're doing that at every one of, as part of each one of our meetings. But is there an area that resonates with you all right now that you think, oh gosh, I can't believe we haven't delved deeper into this? Or do we want the team to kind of help us research it a little further? Do we want to bring in a speaker? Is there a specific area? And I see your hand, Sharonda.
For me, one of the things that jumped out and kept jumping out for me with the data was how the mortality rate was higher when the mother was receiving benefits from the state, like WIC, right? How it was higher than the ones who had private insurance. And I have my personal idea as to why, that kept sticking out, but I don't know if this is something that has been looked into in the past, or if it's something that we could dive into a little more, because the whole purpose of that supplemental benefit is to help. And for some reason, it's not sufficient enough. So is that something that has been looked into?
That's a wonderful question, Sharonda. And I think you probably have some ideas of the answer, as realizing, I think it was, I can't remember who was presenting. I don't remember if it was Danielle. If you were presenting when you were overlaying what I call maps, one on top of the other, that basically says some of the challenges that we're dealing with are, again, not just the clinical part of the world, but we're dealing with our social determinants of health, which is our determinants of health. So we're looking at issues of socioeconomic status, and we're looking at issues around how does housing impact this? How are some of the larger issues that are impacting it? And I think the one slide you had, Danielle, was related to WIC, but we know WIC is one piece of the puzzle. WIC helps some with making sure that we are dealing with food insecurities, but we know, again, it is one component and realizing many of our families need more than one. So that's a great point, Sharonda, and I'm putting it down as a note for us to do some more follow-up on that. And Kate, I see your hand.
Yeah, Belinda, I still feel relatively new to the committee and was so impressed that the committee focused so intently, kind of on one topic, and produced the report that y'all, the people that have been on this group did for a while. And I'm just wondering what our next big thing is, as you're perhaps asking. And in listening to what you said, Belinda, you're seeing the need to, not have put recommendations out there, but put out actions. And how do we get there? I mean, how do we get there in a public health field where we need to be, totally focused on health equity and the importance of that. And I think you believe, and I've become more and more appreciative of the fact that the community engagement aspect of our work in how we implement change is as important and even more important than how we kind of discover what change should be. The different practices that can make a difference. And I'm wondering if there's a possibility for the group to enter into an exercise where we look at community engaged implementation and what strategies, what emphases might be out there that we could most impact change if we took that approach. I'm just kind of throwing out an idea, but I'm listening and wondering what can be our next big thing, and it may be community engaged implementation of selected things and how we go about that, and having almost a playbook to do that.
Thank you, Kate. You know me well, don't you? You're in North Carolina. So
I'm
thank you,
listening to
Kate.
you. You taught me a lot.
Do it together. Thank you. Phyllis, I see your hand as well.
Yeah, I guess I was kind of thinking along the same lines and picking up on something that Dr. Warren said about based upon the recommendations from the report we just did, the value of going to communities. And so I was thinking in those 13 states that had the most significant infant changes in maternal mortality and those indicators, are there best practices? Is there a consistent trend? Could we do some deep research to see what might be related to those things? And do we eventually go to one or two of those communities and just kind of look at what that best practice looks like, or convene a meeting where those people implementing those best practices or initiatives or integrated healthcare or whatever it was, they come and talk about their programs, so that maybe we develop some recommendations that would be actionable steps that other communities struggling might consider.
Great point, Phyllis. Thank you so much. I'm really trying to think through. So what is working in different parts of this country, especially when we're talking about a part of the country that is diverse? Because some of our challenges is the fact that, in certain communities, we're going to see worse outcomes. So how do we make sure we are connecting with those entities, those states, those communities, those organizations that are actually seeing improvements, and what are the lessons learned from them? So I like that idea, Phyllis. Thank you. Anyone else?
I think one thing I noticed is that, mental health was just a huge indicator. I was associated with a lot, just mental health issues came out. So I was associated with maternal mortality. And I just wonder if we need to dig deeper into that and the reasons. I think I personally would like, I think since that just continued to come up, especially, and that there were, I think that was something that was consistent. It would be nice to kind of dig deeper and to find out why. And maybe if that data is there, maybe we need to look closer at that. And I guess I would like to understand too better, when the data is analyzed, like, can they actually pull that data out? Is there enough data there to actually understand how mental health issues were associated with the death? So those are just some of the questions that I have.
Tara, and I see Kate dropped in the chat the fact that mental health illness is not part of ACIMM data, severe maternal morbidity data. And I don't know if many of us had thought about the fact that it is not even included, and it definitely should be.
That's a great point.
Yep. Anyone else? Anything going on in your part of the world that is working or that you're struggling mightily with? Yes, Jacob.
Apologize. I know I sort of beat this drum every time, but it's even more relevant now that I've moved from Georgia to Wyoming. You know, as we continue our conversations about magnitude of impact, just figuring out how we balance that with places like the Mountain West, where we're never going to pop big on numbers, but it doesn't mean that we don't still have challenges to work through. So how we're balancing that size and count issue with, you know, there are only 500,000 people in my state, so we're never going to pop high on a raw. And when we start to look even at rates, you know, just the fact that we're so sensitive to ups and downs that sometimes our data are suppressed. Just thinking about how some regional thought about that could happen as well. So as we're looking at, you know, the Dakotas with Wyoming with Idaho, maybe there's some regionalization we need to think about in some of the smaller places, because, you know, we have one of the largest reservations in our state, so we can do some important work in equity. But sometimes the smaller states get overlooked. Well, we're a big state, but small population. So just how we balance that in this whole conversation, I think, is something to keep in mind as well.
No, that's a great point, Jacob, and thank you for bringing it back to everyone's attention. Sharonda?
For me, communication, right? We want more community involvement, but how do we go about reaching them? I know there's a big push for technology, but is social media the right way? Is something in the doctor's office maybe a better way? How are we communicating that we want the community to help us? And how are we getting that word out? I think that's what's lacking, at least in my area. I know that's one of the things that's lacking. People have no idea that this committee even exists. So how are we getting the word out?
Thank you, Sharonda. And I see, Kate, you dropped in the chat, improving regionalization and risk appropriate care. Charlene, thank you for your note in the chat as well. So health conditions. And Jacob, I see your hand.
Yeah, sorry, just one last comment. One thing too, just putting on the other hat that I wear is how we start integrating this better into health professions education. Because I think we've got a real opportunity to translate this into how we're training across the whole healthcare spectrum. So we do everything from community health workers to physicians here. And I think if we look at how we can make recommendations, maybe even it might be outside of our scope technically, but ways that educational institutions could play a role in this process, I think is something that we could think through, sort of building on what Sharonda was saying about how do we get messaging out. It might be another way for us to look at this.
Thank you, Jacob. And I don't think that's outside of our purview. I think we can make a recommendation related to it. I know one of the things, I don't know how many of you all are familiar with or work in your states or communities with your area health education centers, your AHECs. They have a scholars program where, you know, they work with students like in freshman, sophomore year in college and trying to encourage them to remain in the health field. One of the things we've been doing in North Carolina is trying to get them to consider the maternal and infant health field. So trying to even narrow their focus down. And more recently, we've been working with our state AHECs to do it further upstream to work with high school students, because we've got to get to the workforce earlier before people, have already decided what they want to do, but also decided how they want to do it. So great point, Jacob. And Maria, I see integrate and transition from maternity to extended postpartum for high-risk communities. Thank you, Marie. And HRSA funds AHECs through, thank you, the Bureau of Health Workforce. So there is a great opportunity for collaboration. Wonderful. We probably want to invite them to a future meeting. Sarah is going to help me remember that, aren't you, Sarah? Thank you. She is not just relying on my memory alone, bless her. Okay. Don't want to cut anyone off. These are all great ideas. And if you think of something else tonight, you can always shoot me an email and I'll have it in the morning, or you can email in the morning. But I want us to continue this part of the conversation. And as we're thinking about what we want to move forward with, we also need to think about any specific resources or supports that we need, maybe related to these areas, to make sure that we're getting the best information that we can have in the decisions that we're trying to make. And Michael, I saw your hand go up and then I saw it go down. So I'm assuming you really wanted to be up.
Sure. Just I think a tag on to that ask is, I think there are a number of efforts, not just in the Bureau, but across other partners within HHS and other parts of the federal government that are working to address both maternal and infant health outcomes. And I think one of the key jobs of this committee is to advise the Secretary on HHS programs, specifically Healthy Start, but also others. But I think there's a great opportunity, these themes of like what's working out in the field and what can we learn from that. Similarly, where are there challenges to bring back to guide us as we think about these funding opportunities? I shared a number at the beginning of the funding opportunities we're putting out. In MCHB, we're primarily a grant-making entity. And so if we want to think about changes to those funding opportunities are key, and hearing from you all on suggestions for how to do that is a great way for us to leverage the wisdom of this committee and your partnerships.
No, thank you for chiming in to share that, Michael. And I can't remember who presented earlier, and they talked about, was it Allison when she talked about the community organizations that they've been working with then to do research, and they've given these 15 kind of like challenge grants. To me, that is a great opportunity to pull other people into the discussion that may normally never be part of the conversation. And these are probably entities that can reach people, but they've never been given the opportunity to actually get some resources to support the work. So I know I was very excited, Allison, when I heard you started to talk about that, and I was writing notes everywhere. So
I think the other thing we could do too is we have the groups that said that they, want to be part of that, and HHS writ large has those names. So Michael, maybe we could even think about how we engage some of these groups moving forward, because it may be a good opportunity at that level.
And I wonder, are you all in that same conversation as you're trying to work more with community organizations that may be representing historically marginalized populations, may or may not be, how you are giving them access to funds? Because, I know with many systems, you spend the money and then we pay you back. And that doesn't work for everyone. That doesn't work for
this
most
changed
households.
the way we do that for sure, Belinda. We changed the way the prize authority works. And the reason we decided to use that was because, so they have to do some work, but we staged the challenge in such a way that we were giving them money throughout as they moved, so that we can't tell them how to use the money at all. We essentially give them a check with a prize. And HRSA has also done some of these through the prize authority. So the way that it is structured is that we decrease the administrative burden. So it was a page for their first application to this, and we brought them in and trained them some for free, but it was short. The next phase, we gave them a check. Now, again, they can use it to build their infrastructure. They can use it another way. It's up to their discretion. But as they move, we're giving them money to potentially support what they're doing in the next phase to get to that final prize. But really, the only thing they need to give us is a bank account. That's a domestic bank account. They have to be a domestic organization and they have to have a bank account.
That is awesome. You need to share that with some other entities.
Well, Michael's done it at HRSA, I know for sure. So it's just, I think it's the way that we structure some of these things and trying, as what we've talked about in our community is we can't keep trying to get to these communities the traditional way, because if we keep doing the same thing, we're going to keep getting the same results, and we're not engaging these communities in a way that is sensitive to what they need, especially small organizations. And we also have to think about how we give them money to move them into a research infrastructure that's respectful of a small group's ability to develop. So we worked a little bit with some nonprofit partners like at March of Dimes and at Commonwealth to think about how to structure the prizes as well. So it was respectful of those groups.
Thank you.
I think, and if I could add, the prize mechanism is a great opportunity that we have. We also are looking at just our traditional grants and where we have flexibility. So simple things like we've heard from community-based organizations requiring us to spend so much money on evaluation takes money away from direct services. And so how can you simplify that or think about supporting awardees and other ways to do that? We've heard things like just the number of pages you require in a grant application is overwhelming. And so for folks who are very focused on service delivery, it may be difficult to do that. And so we're trying to revise our grant making process where we've got the authority to be more flexible so that it opens up the door for more folks to apply.
That is wonderful. And actually, Allison, I was thinking you should share it with some states. I wasn't really talking about Michael. I'm thinking of some other places that need to.
Yeah, and I don't know if states have. That's interesting because I know the federal agencies have prize authority. I don't know if states have given themselves prize authorities, but I'm sure they have flexible ways to get funding out that may be different.
We're working on it. We'll see. But thank you so much. And also, I do remember years ago, Michael, that through the Healthy Start world, there used to be capacity building grants. So entities would have like a year to plan and get ready for a larger grant. And, that is one of those other areas that I really felt like it gave communities, smaller entities, the opportunity to actually apply for those resources. And I think that's another opportunity. I just look at it as. Okay, don't want to cut anyone off, because Belinda could keep talking about this topic and she will move on. We do have an agenda, but we're at open discussion now. So we didn't plan anything specific for open discussion. Wanted to use it as an opportunity. If there's anything you want to share, anything about today's meeting, anything about tomorrow's part of the conversation, anything that you're concerned about, anything that excites you, your plans for the evening. You will quickly learn that Belinda does not believe in just holding you here for a meeting, because we put 15 minutes down for open discussion if we don't have anything specific to discuss. This has been an awesome meeting today. You all have done a really good job of being engaged, and please know I appreciate that. It is really hard to chair a meeting when you look down and there's no one there. You're like, okay, can only talk to myself for so long. So thank you all so very much. I don't really have an assignment for tonight or anything that we're encouraging you to do, but if you get a chance in your spare time, just we're working on trying to shorten the size of the briefing books so that they don't feel so overwhelming when we receive them. So if you get a chance to, glance through a page or two, the information on the frameworks, I think it's on page 124 if you want to just look at it, but you will not be quizzed on it tomorrow. We probably won't even bring it up, but if you will look at that if you get a moment. Otherwise, Anything else we need to share for today? You all for the notes in the chat. Otherwise, we will adjourn for today. We will start back tomorrow at our same time. Keep in mind tomorrow's focus. We'll start out with Sharonda, and we really appreciate Sharonda, her willingness to share her story and her journey that has brought her to this committee. But we'll also spend most of our day really listening to our partners. We've asked our partners to come in and share specifically what they're doing through their networks to address maternal and infant health, to see if there's an area that may resonate with us that we want to move forward and try to elevate with them. So just know that that is going to be much of our conversation tomorrow. And we look forward to seeing you all. Please enjoy your evening. Try to get outside for a moment if it's not too cold where you are. And otherwise, I look forward to seeing you all tomorrow. Take care.
Thanks, everyone.